All right, good morning and welcome to the first day of the 13th annual Sentinel Initiative Public Workshop. I'm Mark McClellan, the director of the Duke-Margolis Center for Health Policy at Duke University. On behalf of our center and the FDA, I'd like to add to the welcome to you all for joining us today. Also, I'm an independent director on the boards of Johnson & Johnson, Cigna Alignment Healthcare, and Prognum IQ, and have received advisory fees for Arsenal Capital, Blackstone Life Sciences, and MITRE. We are convening this workshop at Duke-Margolis under a cooperative agreement with the Food and Drug Administration. The conversation today, which is supported by a cooperative agreement with the FDA, is not a federal advisory committee, will not be voting or making recommendations or otherwise. Rather, this is an opportunity to get up to date. This annual workshop serves to bring together people from the increasingly broad Sentinel community, along with leading experts and interested stakeholders, to share key developments in the Sentinel Initiative from the past year, as well as to look ahead in ways to promote engagement, collaboration, and supporting the initiative and having the maximum possible impact. There's certainly more to talk about this year, I think, than ever before. I'm going to start out by reviewing some of the presentations and panel discussions that we'll have over the next few days. I think it's on the next slide. We're going to start with a keynote presentation from Dr. Patrizia Cavazzoni, who is the director of the Center for Drug Evaluation and Research at FDA. Next, we'll be hearing from Sentinel Initiative leadership in a fireside chat, giving us a high-level overview of their work during this extraordinary past year. And we'll have a panel discussion with representatives from Sentinel's Coordinating Centers, where we'll hear about their work implementing their master plans and other ongoing projects contributing to the further evolution of the Sentinel Initiative and related activities at FDA and in collaboration with the private sector. And finally, to close out the first day today, I'll be sitting down with Rob Califf to discuss Sentinel's ongoing work to build robust evidence generation systems and how that fits with some of the broader developments happening around evidence generation in our healthcare system. So lots to cover today. Then next on the next slide, I think we're going to focus more on Sentinel and BEST's work. BEST is the effort led within the Biologics Center on better evidence for surveillance. Sentinel and BEST work related to COVID-19, beginning with a panel discussion on Sentinel's collaborators for pandemic response. Then we're going to have that panel discussion with representatives from the Center for Biologics Evaluation and Research and other federal agencies on how they've worked together to meet the unique challenges that COVID-19 has posed. And then in our final session of the event, CBER and their collaborating partners are going to talk about their ongoing work under BEST, including the development of vaccine safety protocols, which has obviously been front and center during the COVID response over the past year. Next, just a reminder that Duke-Margolis is a part of Duke University, and as such, we honor the tradition of academic independence on behalf of our faculty and scholars and our research team members. We want to see everyone feeling free to speak their minds, but keep in mind that we're expressing own opinions on important issues. We're not taking a political position. Now just one more slide for some virtual meeting reminders. I want to encourage everyone to contribute to this meeting through the Zoom Q&A function. That should be down at the bottom of your Zoom screen. We in the FDA want to make these discussions as responsive and engaging for all of you as possible. So please don't hesitate to submit questions, and time permitting, we'll hopefully be able to incorporate some of these questions into our panel discussions. We'll be doing that in the course of moderating the sessions today and tomorrow. You can also join the questions on, and I should say too, some of our panelists may be able to respond to the Q&A questions via the response function there as well. And then we also encourage you to join the conversation on Twitter, where you can use the hashtag Sentinel Initiative, to share content related to the workshop. And without waiting any further, since we have so much to cover today, I'd like to turn right to introducing our keynote speaker, Dr. Patrizia Cavazzoni, the Director of the Center for Drug Evaluation and Research at FDA. Patrizia, thanks so much for being with us and for all the work at CDER on Sentinel.
Good morning, everyone. I'm sorry again for the technical glitches. I am Patrizia Cavazzoni. I'm the Director of the Center for Drug Evaluation and Research at the FDA, and I have the privilege of welcoming you to the 13th Annual Sentinel Public Workshop. Since the founding of the Sentinel Initiative in 2009, the Sentinel system has supported numerous regulatory decisions at CDER, ranging from labeling changes to safety assessments to providing data that offers review teams context on applications undergoing FDA's assessment. Over 50 summaries of such FDA assessments involving Sentinel-generated data are posted on the Sentinel website. So how did we get here? I will take us back to 2 years earlier and to provide some context. In January 2019, FDA published a 5-year strategic plan for the Sentinel system, outlining strategic priorities. As FDA set about implementing that plan and building on Sentinel's infrastructure, the virus that caused COVID-19 arose and spread across the globe. However, rather than thwarting Sentinel's progress, the pandemic accelerated and galvanized Sentinel's efforts. As you will hear today, you will see how Sentinel's capabilities expanded during this challenging pandemic, not only to address the COVID-19 public health emergency, but in continuing FDA's essential work of helping to ensure the safety and efficacy of drugs and biological products. Now, just over halfway through the Sentinel system's 5-year strategic plan, we have 3 coordinating centers, an operations center, an innovation center, and a community building and outreach center. The operations center has continued and expanded projects to achieve the goals of the strategic plan. The innovation center and community building and outreach center have developed master plans that each describe a roadmap of projects to achieve the specific goals outlined in the strategic plan. We have begun implementing along these roadmaps, with some projects not only initiated, but also completed. Other projects are well under development. Today, you will hear about Sentinel's progress along the roadmap in our presentations in the workshop. This is a preview of Sentinel activities that you will hear about. So first, you will hear about maintaining and enhancing the foundation of the Sentinel system. You will hear about our recent advantages with Sentinel's common data model to increase data capture, such as adding a prescribing table to better understand prescribing patterns that may affect medical product safety and use. We will also cover diversifying data sources, especially electronic health records and claims linked to EHR. Sentinel leveraged partnerships with several database systems to provide near real-time monitoring of therapeutics in response to COVID-19 while increasing geographic diversity. You will also hear about incorporating advanced analytics in Sentinel. Sentinel completed projects building on the use of natural language processing and machine learning to improve identification of health outcome of interest. A recently completed project showed that by using NLP and machine learning, it was possible to develop an improved algorithm to identify anaphylaxis in EHRs. A second project demonstrated the feasibility of developing and validating a claims-based health outcome of interest algorithm using machine learning classification techniques applied to a linked claims EHR database. The pandemic accelerated our development of innovation activities. Sentinel used natural language processing and text mining to identify COVID-19 patients in EHRs and to extract clinical features from unstructured EHR data, such as, for instance, duration of mechanical ventilation, symptom severity, oxygen saturation, supplemental oxygenation requirements, etc. Sentinel continues to develop NLP-assisted chart abstraction tools for cohort identification, exposure assessment, covariate assessment, and outcome ascertainments in EHR data. Developing such tools in advance of urgent safety needs and public health emergencies, along with reusable computer programs, use time savings. We will also be covering broadening such touch points for participating in Sentinel's development. FDA has been working with the Coordination Center and a robust infrastructure comprised of academic-based leads and a broad network to of collaborators in academia, industry, and other settings with related expertise to develop Sentinel capabilities in alignment with Sentinel Systems' 5-year strategy. It is also important that we discuss the establishment of a Sentinel scientific community and disseminating knowledge to improve public health. You will hear about the work of our coordinating centers to develop a portfolio of community building projects with an aim to increase awareness of the Sentinel Initiative for a more diverse scientific community. Our progress along the master plan roadmaps has also led to increased methodologies to enhance FDA's effort to use real-world data to generate real-world evidence for regulatory decisions. You will hear about the parallel development and milestones from FDA's Center for Biologics Evaluation and Research that has been working through the Biologics Effectiveness and Safety, or BEST program, and also in FDA's Center for Devices and Radiological Health, and their work through the National Evaluation System for Health Technologies, or NEST system. I would like to conclude by thanking you, all of you who have participated in and continue to participate in building the Sentinel Initiative collaboration, public, academic, and private entities that are strengthening this national resource. I would also like to thank you for attending this virtual 2-day meeting and thereby expressing your continued interest in being a part of this journey towards Sentinel's further development and advancement into the future. Now, let's hear some of the progress and innovation that will be described in today's presentations.
Great, Patrizia, thank you for getting through those initial technical difficulties. A great overview of the topics that we're aiming to cover today. And again, it's going to be very important to hear over the next couple of days about all of these expanded efforts around electronic medical records, advanced analytics, and then building out a broader community, all in the context of responding to the pandemic as well. And to kick that off, I can't think of any 3 better people to start with than the ones that are joining our fireside chat on the Sentinel Initiative with Sentinel Initiative leadership right now. That includes Gerald Delpon, who's director of the Office of Surveillance and Epidemiology at FDA's Center for Drug Evaluation and Research, Stephen Anderson, director of the Office of Biostatistics and Epidemiology at FDA's Center for Biologics Evaluation and Research, and Daniel Caños, who's director of the Office of Clinical Evidence and Analysis at FDA's Center for Devices and Radiological Health, so covering the whole spectrum of medical products here. We're going to start out with some opening comments from each of these Sentinel leaders, and then have a little bit of time for discussion. I see we've got a couple of questions in the Q&A already around issues like EMR and incorporating new kinds of claims data for Medicaid as well. So maybe we'll hope to get to more of those too. But right now, I'd like to start out by turning to Gerald for your initial comments.
Great, thank you, Mark. And I'd like to thank Patrizia for her opening remarks. And like Patrizia, I'll be speaking without slides. I know there were some questions in the chat about whether there were slides. I'll be speaking without slides. Well, good morning to everyone. I'd like to welcome you all as well to the Sentinel annual meeting. And let me just give you a little overview about what's been happening, but you'll hear more details in all the subsequent sessions. Sentinel's infrastructure, which links data from multiple sources, along with its ARIA tools and reusable computer programs became a powerful resource for us at FDA during the COVID-19 pandemic. It allowed the Sentinel system to initiate numerous activities to protect and promote public health during the pandemic. And some of these activities include monitoring critical drugs to assess changes in utilization over time and by geography, describing the course of illness amongst hospitalized COVID-19 patients, including their characteristics, healthcare utilization, disease progression, and outcomes, evaluating the use of computable phenotypes to help identify COVID-19 positive patients in real-world data, developing an adaptable protocol design to support a variety of on-demand queries and support subsequent studies of the safety and effectiveness of treatments in COVID-19 patients in special populations, such as pregnant women and children, and assessing the occurrence of coagulopathy and its risk factors amongst hospitalized COVID-19 patients. Sentinel has also been collaborating with the Reagan-Udall Foundation and Friends of Cancer Research in their evidence accelerator. However, because we're going to hear more about Sentinel's COVID-19 work tomorrow on day 2 of the annual meeting, I'm going to shift my focus now to developments and milestones achieved in what you might want to call our routine, but certainly essential work of ensuring the safety of medications and biologic therapeutics. So I'd like to start by describing a proof of concept study that's been underway. And the aim of this was to evaluate a cohort of pediatric patients with evidence of hypertension via clinical EHR-based data on the one hand, and compare it to information derived from claims-based data on the other hand. And understanding the differences between these two data sources, clinical EHR data versus claims, is critical as more and more of the real-world data from EHRs is being submitted to us at FDA. By way of background, the Sentinel Common Data Model includes a vital signs table that can be populated with vital sign measurements from the EHR. 7 data partners representing integrated delivery systems populate their vital signs tables and provide us with an opportunity to assess concordance between claims data and clinical vital sign measures. For this study, valid blood pressure measurements from the vital signs table were defined as same-day systolic and diastolic blood pressure medicines, along with a height measurement within 6 months, and were classified into one of 3 groups: normal, elevated blood pressure, and hypertensive, according to the 2017 American Academy of Pediatrics percentiles. Biologically implausible values were removed. For the purpose of this study, children were required to have at least 3 hypertensive measurements in a 3-year period to be deemed hypertensive. If they had at least 3 elevated blood pressure measurements and were not already deemed hypertensive in that 3-year period, they were labeled as elevated blood pressure patients for that period. Sentinel's percentage of children with clinically measured hypertension is higher than that of other published studies, but the vital signs considered here were from any practice setting, so specialty care as well as primary care, whereas previous work had relied only on primary care measurements. Among patients with high blood pressure measurements, either elevated or hypertensive, Sentinel assessed concordance with claims-based definitions for elevated or hypertensive blood pressure in the same 3-year period when the clinical measures were being assessed. Claims-based criteria for hypertension focused on 3 definitions. 1, elevated blood pressure. This was a diagnosis code for elevated blood pressure. 2, hypertension definition 1 inpatient or 2 outpatient diagnosis codes for hypertension. And 3, hypertension definition 2, any hypertension diagnosis code. We noted poor concordance between identification of hypertension based on claims data and identification of hypertension based on clinical definitions of hypertension, suggesting that studies relying exclusively on claims data could undercapture patients' hypertension status, at least in the pediatric population. More importantly, and clinically more relevant, we noted that children with a claim of pediatric hypertension have a markedly different health status from those without such a claim. Specifically, they have a higher mortality rate, a higher prevalence of comorbidities, and a higher prevalence of antihypertensive medication usage. So this project looked at multiple concepts. First, while evaluating concordance between claims capture of hypertension and vital signs measurement capture of hypertension, the project illustrates how secondary use data, real-world data, from a broad range of clinical practices, both primary care and specialty care, can give rise to population-based estimates of a disease or condition. Second, Sentinel is also using this project to consider whether quality assurance for selected vital signs and laboratory data from a within cohort approach and limit to the data elements needed for the regulatory question at hand might net efficiencies beyond broader quality assurance methods applied to all clinical data elements for all patient identifiers across the Sentinel distributed database vital signs table. So that's that project, but there's a lot of other things going on. Let me describe them. We continue to push forward in a lot of different ways. Sentinel's updated the common data model to version 8.0.0. There are new analytic capabilities being developed for the ARIA, active risk identification and analysis, distributed tools to conduct descriptive analyses on drug dosage and expand information in cohort attrition tables. Sentinel's made major enhancemements to the ARIA tools to enhance visualization capabilities. And through the Sentinel Initiative, we've also conducted analysis in EHR-based data sources, including the National Patient-Centered Clinical Research Network, PCORNet, and Trinetics. And we're also working with our coordinating centers to increase awareness of Sentinel. We continue to post all our analytic packages. We continue to notify sponsors of analyses and results. And the Sentinel website's been redesigned. And I encourage everyone to take a look at that. We've also initiated a public quarterly newsletter. And our Sentinel Coordinating Centers will share the details of this work later on. So I echo Dr. Cavazzoni's observation that we've really continued to expand during the course of the pandemic. And let me turn to my colleagues who will share developments and milestones from our sister FDA centers. So thank you.
Great, Gerald, thanks very much for that overview and the expanding work going on at CDER. Next, I'd like to turn to Steve Anderson.
I'll start by also saying thank you to the organizers for putting together this meeting. I just wanted to sort of set a timer here as well, since the tendency to go long. I'll just start. So our main goal this past year at the FDA Center for Biologics has been to respond to the COVID-19 pandemic by expanding our systems to take on this sort of huge task of monitoring the safety and effectiveness of 3 COVID-19 vaccines. CBER launched the BEST system, Biologics Effectiveness and Safety Initiative, in 2018 as an expansion of the Sentinel system. We also began to expand that in anticipation in early 2020 with the arrival of the pandemic, and then also expanded our longstanding federal partnerships with the Centers for Disease Control, Center for Medicare and Medicaid Services, and the Veterans Administration, and others. So I just wanted to mention that what I'm going to talk about really is an unprecedented U.S. government effort among FDA and its federal partners to conduct evaluation of COVID-19 vaccine safety and effectiveness. And I think many things that sort of BEST brings to the table is really its large data systems covering more than 100 million persons to especially identify rare adverse events for vaccines. So I think it brings a lot of power to the evaluations, and many of the other systems are probably 1/10 of the size. And I just wanted to say also what BEST does is it provides support for decision-making concerning vaccine safety, communications, and labeling information for vaccines. As mentioned, real-world evidence and real-world data has really taken off and accelerated in its use in benefit risk assessments, for instance, to support some of our recent authorizations in many different populations, such as for boosters, and now moving on into the pediatric populations. supports decision-making on licensure of vaccines. So for instance, the recent Pfizer COVID-19 vaccine, which was done in August of this year. So you're going to hear a lot more specifics on BEST and its use to support FDA decision-making in tomorrow's session. So I'm not going to delve into a lot of details, but just give you sort of a higher level view. So as of now, there are 3 vaccines, as everyone knows, I think, that are available to the public through emergency use authorizations, and the Pfizer vaccine is licensed for 16 and above. So that's the Pfizer vaccine, Moderna vaccine, and Janssen's, the Johnson & Johnson vaccine as well. So what we're doing as far as active surveillance, I'm going to talk about, but just remember, other government organizations, the CDC and others, are doing similar types of efforts. So one thing FDA is doing with BEST is near real-time surveillance. So we started that in the 65-year and older population using CMS data systems. We've also been using BEST to conduct studies in the 12 to 64-year-old population using Optum, Health Corps, and other partners. And what this is we're monitoring 16 potential adverse events of special interest based on our authorizations. So I just wanted to say that this is a huge undertaking. We probably have 5 different data partners, 16 different outcomes. Every other week, we're analyzing data. So it's a huge undertaking to do this and do multiple testing week in and week out. So I just wanted to mention that dimension of size. Inferential studies. So if you get a signal out of some of these systems, whether it's near real-time surveillance or out of the VAERS system or others, we do inferential studies. And those are really just for follow-on epidemiological studies with more in-depth detail and chart review. We're doing that currently for several outcomes such as anaphylaxis, but also acute myocardial infarction, pulmonary embolism, immune thrombocytopenia, and others. We're also doing ad hoc analyses, meaning looking at observed versus expected rates to really provide rapid information. So BEST, the Sentinel system, sort of serves as a rapid sort of assessment function. We're looking specifically at myocarditis and pericarditis, specifically in younger persons under 30 years of age, and specifically males, and focusing on the 18 to 24-year-old group of males looking for this particular adverse event. So this also, we're looking even further down into the pediatric populations on this outcome as those data become available too, because this is a particular risk. It can be, it's classified as a serious event, although the condition is mild generally for vaccinees. Myocarditis is a swelling of the heart, and the pericarditis is a covering of the heart. We're also looking at thrombosis and thrombocytopenia, Guillain-Barré syndrome, which are huge adverse events that we have an undertaking to look at. We're looking at vaccine effectiveness studies. We recently engaged the Research Triangle Institute and work group members there to help us look at absolute vaccine effectiveness and relative vaccine effectiveness. And this specifically is for boosters, other populations such as the pediatric populations. So we've developed a BEST infrastructure over the time, and it's really accelerated our resources to actually continue to expand this work. We have Acumen and IBM Watson serving as coordinating centers for our claims and EHR work respectively. So they actually provide efficiencies to FDA to handle the work that needs to be done. In addition to CMS, we have, that I've mentioned, we have CMS, we have IQVIA Health Corps, Optum, CVS Health, as well, providing data sources to BEST right now. Again, this is covering huge populations, over 100 million persons for our claims data systems, and 80 million persons for our electronic health record systems. I also wanted to mention another big, huge effort that is going on is linking of vaccine registries and immunization information systems from 64 localities. So that work is ongoing and in its initial stages. I finally just sort of wanted to wind up by saying we have a community engagement outreach effort as well. That is a coordinating center that is run through Columbia University. You'll hear more about that in tomorrow's sessions, but conducting seminars, training. They also work on method developments and other activities. I just wanted to mention, we mentioned the federal agency interaction, but there's also at the international level, we're working with other organizations such as WHO and then our regulatory partners, such as European Medicines Agency, the MHRA in the UK and others, and sort of just coordinating safety activities. So just to close, our priorities for the upcoming year are continued expansion of our efforts in monitoring safety and effectiveness of COVID-19 vaccines and disseminating and communicating information from those findings. We're building a system that's both agile and flexible in that we've been able to simultaneously respond to and expand the needs of our surveillance in near real time, essentially building the bicycle while we're riding it. We've added new data sources in the past year to increase our ability to assess fresher, quicker data and larger amounts of data. And I'll close finally by saying thank you to all my colleagues at FDA and our partners and collaborators who contribute and make the COVID-19 vaccine surveillance efforts a rousing success. And I'll stop there. Thank you.
Steve, thanks very much for that rapid and comprehensive overview. I know it's been a very, very busy year there, and it's great to hear how much Sentinel and BEST are playing into the pandemic response efforts. As you said, we're going to be talking a lot more about that tomorrow too. Right now, I'd like to go to Daniel for a CDRH perspective.
Hi, good morning. Can you hear me?
Yeah, just fine, thanks.
Great, fantastic. So I'd like to talk about the National Evaluation System for Health Technology, which is an organization with driving quality and efficiency in the use of real-world data to inform medical device development, evaluation, as well as support clinical, patient, regulatory, reimbursement decisions throughout the total product life cycle. What in part distinguishes NEST from other efforts is its foundations as a multi-stakeholder public-private partnership aimed at meeting the needs of members of the medical device ecosystem, including the regulatory agencies, manufacturers, payers, patient groups, physicians, providers, and other relevant stakeholders. As such, it's recognized by CDRH as a collaborative community, which brings together stakeholders to achieve common outcomes, solve shared challenges, and leverage collective opportunities for generating evidence from clinical experience for medical devices. NEST has established formal partnerships to form a research network comprised of health providers, payers, and registries that collect, curate, and analyze real-world data from electronic health records, registries, administrative claims, and other sources. The research network has grown to include 16 institutions covering over 161 million lives, and with NEST catalyzing timely, reliable, and cost-effective development of real-world evidence for the ecosystem. The NEST collaborative community has taken on Unique Device Identifiers, or UDI, adoption and application as its first initiative. The NEST collaborative community is conducting a study of uptake of UDI by health systems. On November 18th, it will host a think tank developing the short and long-term goals for the ecosystem for device identification, which will be informed by the preliminary findings from that study. Also in 2022, the collaborative community will be working towards taking the data quality framework it developed that had guiding principles, and will be looking to evolve that document from 2020 into data quality standards for the entire NEST ecosystem. Apart from the collaborative community activities, NEST is also concluding work on the initial 21 test cases that were meant to inform the stakeholder community about the usability of real-world evidence for expanded indications, new clearances and approvals, and improved malfunction reporting. The NEST Coordinating Center is now endeavoring to complete the build-out of the full system, enhancing functionality with respect to an analytic core, common data model, and data aggregation. Finally, in addition to the NEST UDI, data quality, and system foundational work. FDA has provided funding to NEST Coordinating Center to develop, test, and operationalize solutions to enable ongoing, prospective, active post-market surveillance for identification of known and unknown signals, as well as for signal refinement. We're focusing on our initial outcomes to include mortality, repeat procedures, rehospitalization, and building the capacity out from there. With respect to challenges faced during the pandemic that have really informed the ongoing work to build out the system, we've certainly seen the importance of connecting the pipes, as Dr. Amy Abernethy would say, through which diagnostic test data flows, and it certainly faces numerous challenges, including lack of interoperability of the system, loss or manipulation of data between systems, insufficient data capture at its source, and many other challenges. A key focus for building out the system will be on collaboration with key stakeholders involved in the capture and reporting of diagnostic data, large labs, EHR vendors, health information exchanges, middleware developers, et cetera, to assess the current diagnostic data collection and reporting capabilities, including data completeness, quality, and identify the greatest pain points for targeted improvement within the different systems. This builds off of work in which we have been engaged with the Reagan-Udall Foundation and the medical device stakeholder ecosystem within the Diagnostics Evidence Accelerator. I think it's important to highlight that a lot of the lessons learned through Sentinel development are certainly feeding into the work that's being built into NEST. We have ongoing discussions with OSE as well as OMP on real-world evidence more widely, but also specifically as it pertains to Sentinel. And so certainly leveraging a lot of the work done, but focusing on the challenges that we face uniquely within the medical device ecosystem. So in summary, we're going to have a very busy year ahead of us in building out the rest of the NEST ecosystem, the infrastructure there. Thank you very much.
Great, Daniel, thanks. Thanks to all three of you for covering a lot of ground in a limited amount of time. And as I mentioned, we're going to be following up on many of these topics today, especially on the COVID responses and next steps tomorrow. Right now, I was hoping I could go back to each of you. You all described an expanding set of Sentinel, BEST, and NEST related activities and looked ahead a little bit to 2022. Maybe if I could push you a little bit more on that, on what you see happening broadly, not just in pandemic response for these networks in the coming year or two. A couple of things that people had asked about on chat included applications, not just for safety surveillance, but what have we learned and can it help with questions? And Daniel, you just talked about this, label expansion studies, and Steve, you mentioned the importance of real world evidence in some of the authorization decisions related to COVID vaccines. So maybe a little bit more about 2022 onward on kind of expanding scope and activities, and also questions about additional support perhaps coming through for Sentinel through user fee reauthorization, maybe other activities. Maybe just a big picture. Maybe a couple of comments from each of you. Gerald, maybe I could start with you.
Right, Mark, thanks. Yeah, we put out our Sentinel 5-year strategy about 2.5 years ago, and a lot of it focuses on EHRs and how we can really harness the information in EHRs. We've relied on claims for a long time. It served us well. We've learned a lot. But now we've really taken a deep dive into that next step. I think it's applying artificial intelligence, natural language processing. I think you'll see in Noel Kokoris's paper on how we use Sentinel, how we really had to look into nursing notes from the EHR to really understand how widely used oxygen was, because what we were getting from claims just didn't make a lot of sense. How the identification of computable phenotypes from the EHR data, as I mentioned with the pediatric hypertension example. And then going beyond that, perhaps a little more complicated, would be issues of causal inference, how we can take these data, get the data set we need using the techniques I just described, and then doing what we need to do for causal inference. So there's a lot going on separately, but as part of the bigger picture is using Sentinel for signaling. We've not done that. We started with using Sentinel for more formal analyses, and we are now incorporating signaling through different techniques that have been developed into there. Looking forward to PDUFA 7, continued involvement in throughout the review cycle of where Sentinel may be helpful. So I'll stop there and let my colleagues talk a little bit.
Thanks. And I know we'll come back to some of these issues later on in the meetings. Next, Steve, can I go to you?
Yeah, so I would say for us for 2022, it really is still, we're sort of in the grips of, vaccine safety and effectiveness. So I think that really is our focus. And I think for, just what populations we're focusing on, in addition to the general population, the elderly, now we're focusing as well, new focus on pediatric populations as vaccine is rolled out there. And as Gerald said too, I think, so 90% of our efforts really have been focused on around claims data and vaccines. But as Gerald said, we're also doing EHR work with our blood safety type work, and then new advanced therapies. But as far as what we're interested in, I think too, is sort of signal detection. So we've been doing this near real-time surveillance with max SPRT methods as well. And then what we want to do is try to figure out, are there methods where we could do sampling more infrequently or testing more infrequently to just see if there are elevated signals without using the huge amount of resources that we use to do it on a biweekly basis. And then we're also considering methods like Bayesian methods. So a lot of work around signal detection for us will become important in the next year. And I'll stop there. Thanks.
Thanks. And Daniel, last word for you.
Oh, thank you. So earlier this year, we published 90 publicly available illustrative examples of different types of regulatory submissions that were supported by RWE, showing FDA's commitment to advancing evidence generation with that relevant, reliable, real-world data across the total product life cycle. And we showcase these examples, but this next year, in 2022, we are going to really work with the ecosystem to leverage NEST to make it a reality so that these next 90 examples are coming through NEST. We worked very closely with the 21 test case investigators to maximize the potential regulatory impact of those test cases. But now we're pivoting towards the system. I outlined the elements of the system that we'll be building out. And really, we want to make appreciable headway into using the system in a real way for those labeling expansions you talked about. Some of the low-hanging fruit for evidence generation that really makes sense for the ecosystem. I also mentioned, with respect to active surveillance, that this past year or so has been testing the pipes on active surveillance. But now, now it's a matter of, turning on the spigot and using the active surveillance system for some use cases that FDA has worked with the active surveillance task force and NEST and have identified. And so really, this is the year that the rubber hits the road, and we're very excited about that.
And Daniel, on that, any particular use cases that you want to highlight as we're looking ahead? I know you have a pretty long list that you're working on.
So yeah, I know that we were working on a document with NEST. They put a roadmap out for active surveillance earlier this year, and those use cases will be forthcoming, I think, within a subsequent RFI that's going to map out a bit of what the system is going to be and call for folks to come to the table to provide their thoughts for the system itself. So more to come as far as the actual use cases. But certainly looking for this year to make that a reality.
Great. Thanks very much. I think for all three of you, a lot going on this year, especially with the pandemic challenges, which seem to be turning into some opportunities for expanding out the use of the Sentinel system, NEST, and BEST, and much more to come in the next year. We are going to come back to some of these themes in our ongoing sessions the rest of today. And again, tomorrow is especially focused on COVID issues. So all of you, thank you for teeing this up. Thanks for all you're doing. And I'm going to turn next to our first panel. Before we do that, I want to thank all of you who are sending in Q&As. We're trying to answer some, and some of you are providing some information like links to the website, are very, very important for people to see too. Please keep those coming. We'll try to get to as many as we can. So now I'd like to turn to Rachel Hendrick-Stirrup, the Duke-Margolis Center's Research Director for Real World Evidence, who will be moderating our next couple of sessions.
Mark. I will ask my team if it's all right for them to turn my camera on, as I'll be moderating the next session. Awesome, thank you. All right, well, welcome everyone. We've heard a lot of great thoughts in our kickoff session just now with everyone. So for this session, focused on Sentinel Coordinating Center perspectives, we'll be hearing from representatives of the Sentinel Operations Center, Innovation Center, and Community Building and Outreach Center about their work and also initiatives that they'll be supporting in the future, and also that they have supported this year. So our speakers are Patrizia Bright, Acting Sentinel Program Lead at the FDA, Richard Platt, Professor and Chair of the Harvard Medical School Department of Population Medicine, and also at Harvard Pilgrim Healthcare Institute, and also a Principal Investigator for the Sentinel System. We'll hear from Sebastian Schneis, Chief of the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital. Also Asif Dar, Principal Investigator for the Sentinel Community Building and Outreach Center, and also Vice Chair of the U.S. Life Sciences and Healthcare Industry Leader at Deloitte. So we'll go ahead and start with Patrizia Bright, who will begin our opening remarks for this panel. So Patrizia, I'll hand it over to you.
Thank you, Rachel. Can you hear me okay?
Yes, we can.
Okay, so maybe, thank you. So good morning, my name is Trish Bright. I'm an epidemiologist and I've worked at FDA for over 11 years. I'm now the Acting Sentinel Program Lead. Oh, if you could go back a slide, thank you. I'd like to welcome you to the session on the implementation of the master plans that guides CDER's Sentinel work. Next slide. Okay, before I introduce you to CDER's coordinating centers, along with their portfolios of activities in progress, I want to provide you with some background covering a brief recap of Sentinel's history, the 5-year strategic plan, the larger landscape of the Sentinel system, and then, of course, we'll turn to our 3 coordinating centers. Next slide. Okay, Sentinel was launched in response to the Food and Drug Administration Amendments Act, or FDAA, in 2007, and it's evolved over time. The Sentinel system was fully integrated into the regulatory processes in 2016, and you'll see this in the upper right-hand corner. Next slide. For those of you new to Sentinel, the Active Risk Identification and Analysis, or ARIA system, was created in response to requirements in FDAA, and it's a subset of Sentinel system's full capabilities. Next. The ARIA system is comprised of predefined, parameterized, reusable routine analysis tools, combined with electronic data in the Sentinel Common Data Model. As one of the main features of the strategic plan, we're now working to improve these capabilities, and we're going to discuss some of these efforts today. Next slide. Dr. Cavazzoni mentioned the key messages from the 5-year strategic plan. I won't read them aloud because she's already touched on them, but they're on this slide as a reference. The Operations Center has a number of projects underway that align with the goals of the strategic plan. The Innovation Center and the Community Building and Outreach Center have developed master plans that each describe a roadmap of projects to achieve their specific goals outlined in the strategic plan. Next slide. Some of the projects are listed on this slide. Projects include using natural language processing, or NLP, and machine learning to improve identification of health outcomes of interest. There are also projects designed to build a queryable electronic health record, or EHR, system to support Sentinel work. The projects focused on outreach to expand the user base and strengthen Sentinel as a national resource. Next slide. You'll hear about a range of regulatory activities, such as Sentinel's work to develop its signal identification capabilities. You'll also hear about some of Sentinel's COVID work, although there'll be more discussion details on that tomorrow. At the bottom of the slide, you can see that the ARIA analyses that have been conducted by quarter. Examples of level 1 analyses include descriptive statistics for cohorts of interest, or identifying and extracting cohorts of interest, such as cohorts based on exposure, cohorts based on outcomes, cohorts based on continuous enrollment requirements or relevant age, etc. Level 2 analyses are inferential analyses with the primary goal of conducting a well-designed study to make causal inference about medical product safety. Next slide. I'm going to jump back to the timeline. You'll notice in the lower right-hand corner that it ends in 2019 with FDA establishing a new Sentinel Innovation Center and Community Building and Outreach Center. Next slide. I'll briefly describe each of the 3 centers. The Sentinel Operations Center is led by Harvard Pilgrim Healthcare Institute in collaboration with over 40 other entities. The Operations Center implements Sentinel's Active Risk Identification Analysis System, what we refer to as ARIA. This involves maintaining and updating the key elements of Sentinel, including the data partner network, common data model, and routine querying tools. The Sentinel Operations Center works with the FDA to conduct regulatory analyses evaluating the safety and effectiveness of medical products, and supports FDA's commitment to transparency by posting on the web the ARIA analytic packages, results, and regulatory outcomes from these analyses. The Innovation Center on the upper right is also led by Harvard Pilgrim Healthcare Institute, along with their co-leads. The Innovation Center engages with academia, the technology industry, and others to develop innovative methods to further advance Sentinel's capabilities. The Innovation Center focuses on the early phases of method development, such as proof of concept. This is distinct from the Sentinel Operations Center role, which focuses on deploying new analytic tools for routine use. Some specific goals of the Innovation Center include developing approaches for better utilizing data from EHRs, exploring additional signal detection methodologies, and causal inference approaches, and incorporating advanced analytics to further advance Sentinel. The Community Building and Outreach Center, also known as CBOC, is the third Sentinel Coordinating Center. It's led by Deloitte Consulting in collaboration with IQVIA and Nova Research. The goal of the Community Building and Outreach Center is to enhance the Sentinel's scientific community. Specifically, they maintain and improve the Sentinel website to enhance communication and uphold the FDA's commitment to transparency. In addition, they're enhancing usability, search, information management, and community engagement around Sentinel projects, tools, and results in order to encourage broader uptake of Sentinel resources across the scientific community. We're privileged to have the leadership from each of these centers at this session, so we can hear what each center has been doing and how Sentinel's data, methods, and tools are being further developed and leveraged as a national resource. With this background, let's hear from Dr. Rich Platt.
Okay, thank you. Just a sound check. Can you all hear me?
Yes, we can.
Okay, terrific. I'm going to take us one level deeper on the activities of the Operations Center. The good news is there's a terrific amount of material worth sharing. The bad news is we don't have time to talk about it all this morning, but I'll try to pick the highlights. Go to the next slide, please. Patrizia mentioned that Sentinel is a very large village, and these are the organizations that currently participate in Sentinel. Next slide, please. These are the organizations who bring not only their scientific expertise, but provide the data that is the foundation for Sentinel's claims administrative and laboratory data. On the next slide, you can see that we have close to 800 million person years of data and are actively following 64 million people who are accruing new data. Next slide, please. These are the organizations that are contributing EHR data. In the upper right, you can see the integrated delivery systems that have both claims and EHR data that can be linked. I want to point out that HCA Healthcare is the nation's largest hospital network. It has inpatient data for approximately 5% of all the inpatient care in the US. Trinetics, Veradigm, and Procornet together account for well over 100 million people who are accruing data. Next, please. It can't be said often enough or too emphatically that that the data that these organizations collect as part of their routine operations are essential, but they're not sufficient. This is a slide I borrowed from the Duke-Margolis team that makes the point that there is an enormous amount of work that's required to curate that data and make it useful for FDA's purposes. And the kind of curation depends on the kind of data that we start with. So that curation of claims data is different from curation of EHR data. We will be posting soon our protocol for curating EHR data, but curating inpatient EHR data is different from curating outpatient EHR data. Next slide, please. This is the common data model. As Gerald mentioned, we have upgraded the data model in the last year. Next slide, please. Gerald mentioned that we have added a prescribing table so that we can now compare prescribing to dispensing. Next slide. We now have a table that captures provider specialties, sometimes very important in understanding how to interpret diagnoses and treatments that the patients receive. And next slide, please. We've upgraded 4 of our tables to make them compatible with international coding conventions so that it's possible to write queries that will run against other countries' data when it's put into Sentinel data model format without requiring any additional mapping on their part. Next slide, please. This is a snapshot of the regulatory actions that Sentinel has informed since 2016. I want to draw your attention to the upper right, the substantial number of situations in which Sentinel queries have basically provided the evidence that regulatory action is not needed because it acted as what we sometimes call a signal quencher. Next slide, please. Gerald mentioned that we are bringing a signal identification system online. This is a substantial new addition to our to the reusable tools that we use to support many of Sentinel's activities. We've been testing the tree scanning protocol for a number of years and believe it's now ready for prime time. Next slide, please. And we anticipate, as Gerald mentioned, that one of the early uses of this will be for surveillance of outcomes of pregnancy, both the maternal outcomes and infant outcomes. And the reason we'll be able to look at infant outcomes, next slide, please, is we have 5.5 million linked mom-baby pairs, so that it's possible to connect the prenatal exposures to the outcomes among the newborns. This is a substantial amount of work over years has gone into allowing us to build these links, and we anticipate that this will be an important addition to FDA's capabilities. We're now in the process of converting Medicaid data into Sentinel Common Data Model format. That's going to need its own extensive data curation work, but since Medicaid covers nearly half of all U.S. births, we expect to more than double the number of linked mom-baby pairs by the time we're ready to bring these online. Next slide, please. We have been working for several years on pandemic preparedness. That work was started under the auspices of the Office of Counterterrorism and Emerging Threats at the FDA, well before the COVID pandemic was on the horizon. But over a number of years, we have learned a great deal about how to use electronic health record data to answer the kinds of questions that are important in pandemic situations. And this year, we've published the first of 2 of a series of articles about how to use these records to prepare for pandemic, using influenza as the case study. But this work put us into a very good position to be immediately helpful to FDA in responding to the COVID pandemic. Next slide. We've written this up in this article that describes the Sentinel system as a COVID-ready public health surveillance system that has proved to be quite useful. And this will be the topic of a considerable discussion tomorrow, so I'm not going to say much more about this. Next slide, please. But I do want to follow up on Gerald's comment about the use of EHR data to gain new insights into the care of patients. These are EHR data from HCA Healthcare. We're using coded data, even the EHR coded data. We found that 28% of individuals were receiving oxygen support. Doing a deep dive with the staff at HCA Healthcare, we were able to use the semi-structured nursing notes, which required a fair amount of translation and mapping, to show that actually 79% of all their hospitalized patients were receiving some form of oxygen supplementation. Next, please. This is a placeholder slide to talk about some of the real-world evidence work that we're doing. Bob Ball and John Concato are going to talk more about this in a few minutes, and so I'll merely use this as a placeholder to say we have a substantial portfolio of FDA-supported work on real-world evidence. Next slide, please. In addition to the FDA-supported work, some of our real-world evidence work is now being picked up by other organizations. PCORI is funding a juvenile inflammatory arthritis study that's using the MyStudies app that allows individuals to provide patient-generated information. The Crohn's and Colitis Foundation is supporting a study that uses this app for a study of inflammatory bowel disease. Next, please. We're working with the CDC and NIH on a couple of studies that I'd like to share with you. Next slide, please. With the CDC, we've done a study looking at the use of post-exposure prophylaxis against Lyme disease. We have over 400,000 people who've been exposed to this prophylaxis. You can see on the left-hand panel is the CDC reports of Lyme disease cases. The middle panel shows the counts of the number of post-exposure prophylaxis dispensings. And then because we have information about the eligible population, we're able to show the population density in the right-hand slide and show that it maps almost perfectly to the disease incidence. Next slide, please. For the NIH, we have built what's called the NIH Collaborative Distributed Research Network, and many of the Sentinel data partners participate in this. Next slide, please. It provides a vehicle for NIH and other not-for-profit sponsored investigators to conduct research with their Sentinel data partners when they need to work with more than one data partner at a time. This is a study that the National Institute of Aging has funded to try to improve the safety of medication use in patients with dementia. Next slide, please. This is a 3-arm cluster randomized embedded pragmatic trial of over 11,000 patients to try to reduce the use of inappropriate prescribing in elderly Alzheimer's disease patients who are living at home. Next slide, please. We have made considerable strides in working with international partners, Canadians, the British, and the Danes. Gerald mentioned, next slide, please, a proof of principle study we did. One more click, please, to test the ability to use a single query across all 4 countries to study the use of nitrosamine contamination and angiotensin receptor blockers. And the good news is the same query ran without modification in each of these 4 environments. Next slide, please. We plan to use that capability for 3 international partnerships during the next year. These will be discussed in some detail tomorrow. Next slide, please. And the final thing I want to say is we've put considerable effort into building better ways to use the reports that we generate. Patrizia mentioned that there are dozens and dozens of reports on the Sentinel website. Each report consists of dozens or hundreds of tables, which, to be quite honest, are just not easy to read. And we're building a dashboard that will give visual display of many of the important outcomes that we find through these queries. So we hope this will make Sentinel's work much more accessible to a larger number of people. Next slide, please. That leaves me to say the work I've described is the contribution of hundreds of people, and this is a not fully sufficient way of thanking them, but I do want to have their names scroll before you while we're making the transition to the next speaker. So thank you very much.
A lot of great information that you just presented, a lot of considerations along the real world evidence spectrum of opportunities. So thank you again for presenting all of this information to us today and to everyone today. So I will go ahead and turn it over to our next speaker, Sebastian Schneeweiss. I'll turn it to you.
Wonderful. Thank you, Rachel. Thank you, Rich and Patrizia, for setting this up so beautifully. I'm reporting on our progress at the Innovation Center. Next slide. Which is one of the two new centers clustered around the Operations Center. It was motivated largely by further improving the utilization of electronic health record information that is complementing the claims data analysis that the Sentinel system has been using for quite a while already in order to expand the ARIA system. Next slide, please. Next click, thank you. We have a bunch of initiatives, which I'm going into in a second. Next click, in order to fulfill our vision for the Innovation Center, which is to build a query-ready, quality-check distributed data network containing EHR claims linked data. We want to have the best of both worlds, the clinical granularity of information from the EHR with the continuity of information and the enrollment files that claims data have, link those together for at least 10 million patients with modular analytic tools that can be run across this system. Next slide, please. The four key initiatives that we have identified are the data infrastructure initiatives very closely together with the Operations Center. How will this additional very granular information make its way into the very flexible Sentinel common data model? Next slide. And how do we prepare these raw data, these secondary data for analysis? There's a lot of work actually happening in this space where we use natural language processing to extract information, automated feature extraction, computable phenotyping to get the raw data analysis ready. Next click. Which brings us then to the analysis of such data in order to come to causal conclusions, how a medication affects health outcomes of interest, where we have a bunch of innovative analytic designs that need to be adapted and tested in this specific data setting where we have EHR information and claims that are linked together for the same patients. Next click. And that leads, of course, to advances in the detection analysis and the signal detection framework, where there are quite a bit of innovations, including the methods that Rich Platt just mentioned, the scan statistics. How will they work with electronic health records? This is a new field that we're exploring, expanding. Next slide. We have developed a master plan over 5 years where we have a range of projects that are closely interconnected and built on each other in order then to fulfill the vision of building this query-ready system. And I will highlight several little projects. Next click, please. First, let's focus on the data infrastructure cluster, a range of projects that we have kicked off and we're about to kick off. Next click, please. Where you see the existing central common data model and infrastructure is very much focused on claims data. Have, of course, already quite a few electronic health record data involved. Next click, please. We are expanding this activity with more depth, analytic depth in the electronic health record space, where we are dealing with structured EHR data, Semi-structured data, we have often lab test results. We work with unstructured data from physician notes, from nursing notes, and develop feature engineering in order then to feed that into the Sentinel Common Data Model to have it query ready across a network of contributors. Next click. So currently we are working on Horizon Scan. We're finishing that up in order to identify the data sources. Next click. It's a bunch of clicks here, thank you. Working with the project DI2 to unstructured data and how they will make their way into the common data model to be analyzable across systems. Next click. We have a project that is developing what we call Death Index 2.0, which is accelerated information on the date of death as well as the cause of death, and it is linkable to the Sentinel infrastructure. Next click. We need to worry about data mapping, of course, with these new data assets. Next click. And we have to think about how to harmonize the data that we have identified in the different data assets in order to expeditiously run analysis across multiple data sources that are linking EHR data as well as claims data together. Next click. Moving on in our master plan to feature engineering, we have one project I want to highlight. Next click, please. This is a project that is led by David Carell from Kaiser Permanente in Washington and Josh Smith from Vanderbilt University. The objective is to develop scalable, reusable methods that incorporate unstructured EHR data and scalable natural language processing methods into Sentinel. We are using as much as we can existing methodologies. We are pressure testing this. We are standardizing this. We make it scalable across, here you see it, structured, semi-structured and unstructured data in order to improve cohort identification based on markers not available in claims, but only in EHR data. Better measure clinical conditions and also better identify health outcomes of interest that might not be fully characterized in claims data. So part one, the project that you see here is part of the COVID cluster project, where we seek to identify generalized methods for cohort identification, identifying do these patients truly have COVID or do they have other infectious diseases that are not quite qualifying for COVID. Next slide, please. Part two of this project it focuses on scalable and reusable NLP tools and methods for measuring clinical conditions to identify the exposure, to identify pre-exposure covariates, patient characteristics that will be used for confounding adjustment, as well as to identify outcomes of interest. And you see this, these systems can be quite complex, and scaling these systems up is the main focus of this activity and activities that are clustered around this project and leading up to semi-automated or at least extremely scalable modular programs in order to analyze the full information content available in electronic health record data. Next click, please. Moving on to the causal inference cluster, what are we going to do with the data once they are developed the right way? Next slide, please. We have developed a fairly detailed next slide, please. Next. We have developed a fairly detailed roadmap for causal inference that is based on the linked data asset and is helping us to develop causal inference analytics. And next click, thank you. Key markers for this is to identify causal study designs, implementing causal study designs, providing support in doing this. And then we have machine learning augmented causal inference. There's quite a bit out there already. We are pressure testing that. We are making it ready for routine use in these types of data in order to make full use of the clinical information granularity. And on the right side, we have machine learning supported endpoint identification. How can we improve and accelerate the identification of validated endpoints with very optimized measurement characters, high specificity, high sensitivity. Next click, please. The previous, next click, thank you. The previous project, FE2, is of course central here. You see the yellow markers of the two projects. Next click, please. In order to prepare the data, And then you see a bunch of projects in blue underlined, CI2, Causal Inference 2. That is the framework that they were developing. How should projects approach causal inference from covering all aspects of design and analysis? We need to deal with missing data in electronic health records, longitudinally missing, cross-sectionally missing data. Next click, please. And then, of course, we have targeted learning, high-dimensional analysis methods for optimally using these very rich data. How do we harness the data in a way that we can build a causal inference infrastructure? Next slide, please. And thank you. The key partners in the Innovation Center are the Brigham and Women's Hospital, the Kaiser Permanente Washington, the University of Washington, the Vanderbilt University, and Duke Clinical Research Institute. These are kind of the four core partners in this. And then we have a range of data partners, of investigators across the nation that are very actively involved. And we hope that we will continue to include even more than those institutions. So thank you very much, and I'm happy to take any questions after Asif. Thank you.
Thank you, Sebastian. We'll go ahead and turn it to Asif.
Hello, everyone. It's good to be with you, and thank you, Patricia Bright, Rich Platt, and Sebastian Schneeweiss for such a great introduction, really, to the topic. As you saw in the Q&A, there was a question about, is there a community building and outreach center for Sentinel? And indeed, there is. And I'm going to walk you through just a couple minutes about what we're doing. You heard plenty from both Rich and Sebastian regarding some of the activities in both the IC and the SOC. And I'm going to take a moment or two to talk to you about the master plan and some of the key activities of the CBOC. So next slide, please. What we're going to start off talking about are the origins and the purpose of the Community Building and Outreach Center, or CBOC, specifically highlight some of the goals, who we spoke to in developing the master plan, some of the key feedback that we got, and how that frames some of the projects that we have done and the projects that we are intending to do vis-a-vis the master plan. So let's go to the next slide, please. The CBOC was created to broaden and activate a strong scientific community to advance the Sentinel Initiative. As you've already heard, the CBOC supports the FDA in 3 of the strategic aims outlined in the previous mentioned Sentinel System 5-year strategy. And so that strategy is something that I'll be talking to you a little bit about today, because the aims are reflected in some of the recommendations that we got in terms of the activities of the master plan. Let's go to the next slide, please. Some of the feedback that we got was interesting and I think very informative. Just as you heard today, there are far number of activities that are in flight, things that have been done that would be very useful to know or have better access to. And so stakeholders that we interviewed, that and those include epidemiologists, informaticians, health advocates, talk to us, the SOC, the IC, and 3 key findings came up. And those findings are the following. Individuals in general suggested a greater desire to understand the design decisions and the specific questions and challenges that the Sentinel system can answer. To understand which tools, methods, data, and infrastructure are already available or will be made available that can be used to inform their work. And 3, increase knowledge sharing and training opportunities to foster collaboration and contribution to the Sentinel community. Let's go to the next slide, please. The CBOC master plan was developed to focus on engagement and awareness of Sentinel. It identifies and outlines a series of projects, describes the action plan, and within the master plan are centered around 2 approaches: functionally communication and training, or a bidirectional engagement model. Let me go through some of the activities so that this comes to life. Simple things like communication, training goals, ongoing website design and implementation, frankly, updating the website. I'm going to get into that in just a moment. Public-facing newsletters on an ongoing basis so that individuals can understand what's being done, what's being worked on. Templates, standardized presentations, and informational videos. Graphics, webinar series, virtual training. So this gives individuals who are interested in Sentinel a pretty useful series of tools to easily access what's been done and what's planning to be done. We're also working on approaches for bidirectional engagement, and that includes, for example, a real-world data form that's coming up. So next slide, please. The following projects within the CBER Master Plan have already been implemented or in progress in order to increase awareness of the initiative, access to tools and materials to date, design of the Sentinel decision or information regarding design of the Sentinel system, to improve usability of the Sentinel tools infrastructure and or stakeholder contributions. So this is kind of your one-stop shop to get access to information. Some of the projects include the redesign of the Sentinel website. For example, the website that you just saw in the chat function is a really great starting point for all of your questions and all of your information regarding Sentinel. The redesign included an updated navigation, a standardized table for search, sort and filter, search optimization, and usability. We went through a redesign of 1,000 pages and a new look and feel. The more than 1,000 detailed pages that have been updated have been used by numerous individuals, and the search function allows for very quick ability to do things like and or quote searches, the sort of things that you're used to doing on most of your online searches. We also have a training center page update, an easy to navigate feature for training and workshops, and a plugin for an upcoming webinar for patient advocates. It also is a one-click access to materials and videos. And we've also engaged the Sentinel page for numerous updates, including a newsletter, which I'll just describe in a moment. We've got a quarterly newsletter that comes out, and already we've gotten up to 5,500 unique clicks, hundreds of individuals accessing the newsletter. And this is an ongoing resource for the community that highlights changes in the Sentinel system, the website, research, upcoming events, recent publications, and work that is ongoing. We believe that the already 5,500 subscribers and hopefully additional ones after today's annual public workshop will allow for enhanced engagement and understanding of what's being done in Sentinel. So I'm just taking a look at time. My colleagues have already gone through a lot of the updates. I was going to go through some of the quarterly updates in the newsletter, but I'll just draw your attention to the newsletter for your review after this session. I'm going to also mention that, like I said, we've got templates, standardized presentation, and informational videos. This actually ended up being a significant request from the community because there are a lot of decisions that have been made for very logical reasons in terms of Sentinel, related to the early data being used, the data that's being used ongoing, and the types of analysis that is done. And so to consolidate that and make that available, there are standardized templates and informational videos that have already been uploaded to things like YouTube and the website. So I'll draw your attention to that. So let's go to the next slide, please. We've got some projected CBER Master Plan activities. They include an ongoing webinar series, as I mentioned. We've a quick plug for a new webinar that will be focused on patient advocates, which I think is important. We are also conducting virtual training on a range of topics, including how to convert data into the SCDM and how to use analytical tools on the Sentinel website. These are joint efforts between all three centers, as you might imagine, the CBOC, the SOC, and the IC. And will be designed around needs of specific stakeholders. We've got a scientific deck that will be made available and a real-world data forum for stakeholders to explore their own data using Sentinel infrastructure and tools to increase the impact of how to use the Sentinel infrastructure and tools and provide areas of potential improvement and innovation in a real-time basis, or innovation in real time, and to determine potential additional return on impact. So given the amount of time we've got today, I'm going to stop there, but of course, we collectively will be open for additional questions and comment. Thank you all for your time.
Thank you so much, Asif. This was a wonderful panel. I think we've learned a lot from everyone who spoke on the panel today. So thank you again to all of our panelists, Patrizia, Richard, Sebastian, Asif. Thank you so much. You know, one common thing that I've heard across every discussant here is that there are a lot of opportunities to leverage data within EHR systems. For example, nursing notes, semi-structured nursing notes being one. Talked a lot about opportunities to design and leverage pragmatic trials or pragmatic embedded trials, such as the Be-Prescribe AD trial. ARIA is the new Sentinel system structure that we can look out for. The Sentinel's Innovation Center that's currently looking at opportunities for leveraging causal inference approaches and also developing other innovative methodologies to analyze EHRs. Asif, you talked about some of your community engagement approaches, one of them being a bidirectional engagement approach or model, and you also have a real-world data forum coming up. So I'll go ahead and ask the first question, probably along that vein, since we just concluded your discussion or presentation. So how, or at least what are your plans for either sustained or scaled community engagement regarding Sentinel? And also, over the past year, how would you say that has sustained or scaled in ways that you hadn't seen before, perhaps?
Well, thanks for the question. One of the major transitions has been to a centrally digital environment vis-a-vis the website. The website's an incredibly powerful tool if made easy to use. And so we spent a lot of time building a robust infrastructure vis-a-vis the website to be able to have a resource that people can engage on an ongoing basis. During our interviews, there was sometimes a misconception about, I wish Sentinel would, and there was already work done in a particular place, but it was hard to get to, so individuals might not have had easy access. So it creates immediate scalability. When you talk about fora, that gives us an opportunity for two-way education, kind of I noted previously, I'm watching the QA today, and that provides an immediate input. When we're working on two-way engagement models, just as like these fora, by identifying key questions, key opportunities for work, the community can actively contribute to a given topic while we're learning both their needs, the use cases, and frankly, some of the challenges that are ongoing. It's natural that they'd be the case, and there are clear decisions that are made. And finally, I would like to say, it's really helpful to have a compendium. There have been literally years and years. Both Sebastian and Rich have gone through a huge number of collaborators that work in this environment, and making that information collectively accessible and then providing information back to that entire community vis-a-vis our other centers is a real opportunity. And so digital first, moving on these two-way fora in the future, and continuing to be great listeners to be able to provide our other centers, the SIC and the SOC and the IC, with ongoing feedback, I think is a real opportunity for the CBOC.
And actually, we do have a question from someone in the chat asking about CBOC. Can the CBOC system allow the traceability to original data facts? I think while we're on that topic, maybe we can shoot a quick answer to that.
Yeah, and I'm going to draw my colleague Rich Platt to this answer, because therein lies an area of clarification. The CBOC isn't inherently independent systems. The whole function is to bring in the community on the Sentinel system itself, and so I'll kind of hand over the question to Rich as well for additional clarification.
So I'd say, depending on what fact you're talking about, the answer is absolutely. That is, we are able to go back from the answer posted on the website through all the analytical code, which is also posted, to the data tools, which are also posted for original use. So I'd say to a large extent, the answer is a simple yes.
Now, thinking about data quality and standards across multiple EHR systems, you all talked a lot about things to consider there. So what would you say is needed to ensure data quality across multiple EHR systems that are contributing or that have contributed to Sentinel?
Well, if you'd like me to start with the answer to that, I would say data quality is something that's assessed data source by data source repeatedly with every time we refresh the data. So I wish there were a simpler answer to that, but we found that even though we've worked with many of these data partners for a very long time through dozens of data refreshes, we still find things that crop up in the data that need to be addressed, and we can almost always sort them out. But we've become convinced that there's no real alternative but to do the sort of hand-to-hand combat of data quality assessment for every organization every time the data is updated.
This is Sebastian. Of course, I very much agree with Rich on this, which is also why it's so important that we continue to have reach through to the original data. If questions come up, we can get back to the original data. The Innovation Center is working on analytic methods that are less dependent on the data quality. It works with the data that they get handed. And we punt this issue then down the road with what we call performance metrics. Of course, if the data have largely missing information and incomplete information, then the performance of the analytic approaches will be less. So all of our projects that we have in the Innovation Center have built in efforts to develop new performance metrics so that when we run these semi-automated algorithms across the data that may or may not be imperfect, we at least get a sense of how reliable the inference is that we draw from such data.
Thank you. If anyone else has anything else to add, I can go ahead and move on to our next question. Patricia or Asif, if you have any ideas or things to share around the topic of data quality across multiple EHR systems.
I just make one last comment. Both my colleagues noted that it's important to know not only the data, but the algorithms, sometimes semi-automated, sometimes more automated than that. But that learning occurs over a period of time. There's no shortcut to the hard work of actually figuring it out. By and large, most stakeholders acknowledge the fact that most of the times you can work it out, but somebody has to work it out. And so making that collectively available to the community is something we see as a real opportunity with the CBOC.
Sure, and this is Trish Bright. I would just add to that, and I think my colleagues have discussed it, but there's really sort of two pieces here. And one is the methods projects that you start with when you're sort of entering into a new data source, and to make sure that you're capturing it right, you're looking at and you're understanding what the data really is. And then the other part is sort of doing this quality control check that you can never sort of stop and give up. You know, you always have to sort of go back and recheck and recheck and recheck. And so they're kind of hitting both of those parts, but there's sort of two issues. One is initiating projects, and the other is the routine quality control.
Now, you're thinking about ways to ensure that real-world data sets are representative and equitable, and then also thinking about, you know, the trajectory that the Sentinel is on to become more useful to many stakeholders, whether it's for purposes of driving, you know, broader equity, broader representation in the data. You know, where is Sentinel's engagement most promising right now in the very, you know, near future along this vein?
Well, I'm willing to start that, Rachel. I'd say that there are two arms to think about. One is a set of tools that we think can be useful to a wide array of people, and those analytic tools are all posted for anyone to use, for anyone who wants to translate their data into Sentinel Common Data Model format. It's become a very rich and powerful tool set for a wide array of epidemiologic analyses, particularly the kind that are important for pharmacoepidemiology. I think that the more promising and exciting possibilities are for partnership with Sentinel data partners to use the very substantial resource that exists for a wide array of questions that aren't ones that FDA is going to support, but FDA has been supportive of their being used for non-FDA purposes. So the kind of epidemiologic public health studies that CDC example I showed is one kind of example. I think health services researchers, delivery science researchers would all find working with Sentinel data partners to be a useful thing to do. I think there is a great upside for clinical trialists who are interested in doing embedded pragmatic research. We're, I think, just scratching the surface with the kind of dementia study trial that I described, and those all build on work that FDA has already supported. So it's not saying that everything's ready for turnkey kinds of activities, but over the 13 years, the system has become extremely capable of doing a very substantial number of kinds of studies that are going to be useful to a wide array of stakeholder groups, including patient stakeholder groups. I also want to just repeat the fact that we expect to be making substantial use of Medicaid data, and that will be an important complement to the commercial insurance that has formed the sort of the foundation of Sentinel for quite a long time, along with the Medicare fee-for-service data that we also routinely use.
Slides, you know, that half of U.S. births currently or to date are among the Medicaid population. So definitely, I think the audience would see your point there in terms of bringing in more opportunities for broader equity and representation in the data. Would anyone else like to add on to Rich's comments?
I'll just emphasize, Rich mentioned health and patient advocates, and I think that that's a wonderful stakeholder group that's been speaking about the interest in use of the tools, and for good reason. And so I just wanted to underline that topic, and the ability to use a substantial capability for those purposes and the purposes of health advocates or patient advocates, I think is an emerging important stakeholder group.
Yeah, and so one aspect, Lily, is to expand the reach to include a variety of people in order to characterize the variability and inequities. But the other thing is, how do we characterize inequities, right? This is in some data assets, we have structured information on race, and but there's way more to that. There's socioeconomic status, the other parameters, which electronic health records, particularly notes, where we then see sometimes, particularly nursing homes, comments like, the care situation at home. So there is a lot of richness in the data that might not yet be fully harnessed in order to fully characterize the inequity in the data that are currently available in the expanded data. So there's plenty of work there.
So actually thinking about the criteria that's used in order to conduct queries or searches across databases, it's usually done, as someone mentioned in our Q&A here, it's usually ICD codes, and that can lead to some exaggerated query outputs, which are problematic. And that's especially when it's compared to other databases that follow different codes. And so is there any work going on, as one of our persons in the Q&A asked, is there any work going on to overcome these sorts of limitations with regard to, the data being coded differently across systems, such that there are challenges and also opportunities to sort of address the coding discrepancies or differences, sort of opportunities to reconcile that?
So I'd say there are two kinds of answers. One is sometimes we look to the data across partners to look for outliers that would suggest that there might be a difference in the way that they use coding systems. One of the most important things about Sentinel that we haven't mentioned today is that every one of our participating organizations is linked to a live delivery system. So it's possible to go back from the claims to the providers, to the original medical records, if needed, to the patients. And so we have done a substantial amount of work where for critical outcomes, we request the records and we have them de-identified and then adjudicated by expert reviewers, so that we have, when needed, we can have gold standard adjudication of the critical data elements.
Yeah, I mean, just to state the obvious, there is no perfect coding system on this world. What is important that we understand how the coding systems are used in specific settings and what the performance characteristics are. What is the sensitivity, specificity of a specific code? That knowledge is critically important, right? Whether that is now in SNOMED and MEDRA or ICD, it doesn't really matter as long as we do understand, right? And hopefully we have then reasonably high performance metrics that are good building blocks for causal inference.
This is Trish.
Oh, right.
I was just going to add to that, that sort of as an epidemiologist at FDA, we do go in and look at the validation, how well codes validate, and we need to sort of report that and make sure that we understand the codes and that they're capturing what they say they're capturing. That's part of what any epidemiologist would do at the FDA. So that's sort of built into our methods, our approach, and our quality. Is this telling us enough information that we could go forward? And I also wanted to mention that Gerald had raised a study that was done that was looking at concordance between the ICD codes in a pediatric hypertension study and vital sign ascertainment. So there are also methods projects that are going on to look at these things in different ways.
Rachel, just to follow up on that, we have way too few of these validation studies, and I think everybody would agree to that. We would love to know more about the measurement characteristics of whatever coding system we are using, which is why the Innovation Center has a track in order to make outcome validation more scalable, because we need more of these activities to understand how well we capture and identify certain health outcomes of interest, right? And it's simply too expensive to always do the traditional validation study where physicians then review hundreds of records and things like that. We need to expedite this. We need to make this more efficient. And machine learning tools can be helpful there. And the Innovation Center has a bunch of projects in that range.
Thank you so much. Awesome. Well, It sounds like there's a lot of exciting things up ahead for ARIA, for Sentinel, especially as we head further into the COVID-19 pandemic. There are lots of things to consider and think about, especially around how the Sentinel system has scaled up its work to meet a range of unique challenges during and in direct relation to the COVID-19 pandemic. So thank you to the panelists once more, Sebastian, Richard, Asif, Patricia, thank you very much. And thank you to those of you who shared your comments and questions in the Q&A. We were happy to present those to our panelists today and look at opportunities for further discussion. So a lot of, as I mentioned earlier, a lot of you talked a bit about causal inference. So our next session will actually focus on that, improving causal inference for real-world evidence generation. But before we go into that next session, we will take a break for about half an hour. We'll reconvene at 12:20 p.m. Eastern for the next session. As I mentioned, it's entitled Improving Causal Inference for Real-World Evidence Generation. So excited about that, especially given what our panelists have prepped us for, or given that our panelists have sort of prepped us for this topic. And so we will see everyone back here at 12:20 after our break. All right, thank you, everyone. And or for those of you who are still tuning in to our Sentinel meeting today, it is now 12:20 and we are back from our 30-minute break. Again, thanks of you for coming back online. We will go ahead and move right into session 2 today, which is on improving causal inference for real-world evidence generation. I am happy to be joined by our colleagues here that you see listed here on the slide. John Concato, Associate Director for Real-World Evidence Analytics in CDER's FDA CDER's Office of Medical Policy. Also, Rich Forshee, Acting Deputy Director for CBER's Office of Biostatistics and Epidemiology. And also Gian Mario Condore, a statistician on the Data Analytics and Methods Task Force at the European Medicines Agency. And lastly, Josh Gagne, Vice President and Global Head of Epidemiology for Johnson & Johnson. Now, as I mentioned from our last panel, our panelists there had a lot of great things to say about causal inference, particularly as the Sentinel Innovation Center will focus on its approaches and others as an innovative type of methodology that has a utility for real-world evidence, or through which real-world evidence can demonstrate its utility. So for the time being, I'll go ahead and hand it over to it looks like Robert, who will be giving his opening presentation. Thank you.
Hi, good afternoon. So my job in introducing this session is to try to connect the work that has been going on in the Sentinel system for many years and is going on right now and will go on into the future, and how that supports FDA's understanding of real-world evidence to support regulatory decisions for drugs and biologics. Next slide. So I'm going to do that in 2 ways. First, I'm going to have a very brief overview of FDA's real-world evidence program, and then I'll talk about some of the activities in the Sentinel system that you've already heard about, but I'm going to try to connect them specifically to how they support FDA's understanding of real-world evidence generation. Next slide. So the 21st Century Cures Act in 2016 required FDA to establish a program to evaluate the potential use of real-world evidence for 2 reasons: support new indications for a drug approved under Section 505C, which is the sort of traditional approach to approval, and then to satisfy certain post-approval study requirements. FDA issued a framework back in 2018 that describes some of the sources of real-world evidence, including the Sentinel system and FDA's experience with it, the challenges and opportunities that are available. So a lot of work has been going on since then, and that some of that culminated in the release of 2 draft guidances just in the last 2 months, one on electronic health records and claims and how they can be used to support real-world evidence generation, and the other around data standards. And it's important to note that the regulatory requirements for substantial evidence remain unchanged by the Act. And so what this program is really about is to try to understand how to take real-world evidence to reach that standard. Next slide. So I'm just going to touch upon 2 definitions in FDA's framework of real-world data and real-world evidence. So real-world data are data relating to patient health status and or the delivery of healthcare routinely collected from a variety of sources, that routinely collected being the key word. And it's really about the, in some aspects, the secondary use of medical claims and EHR data, but also could be prospectively collected registry data or digital health technologies, such as apps that allow engagement with patients. Real-world evidence then is the evidence generated from the use of this data. And key to this aspect of the definition is that it's not just the traditional observational studies, but includes randomization in the real-world setting. And I'm going to touch upon how Sentinel experience has helped FDA understand both of those. Next slide. So the key considerations are FDA has put into these 3 components. First, whether the real-world data are fit for use, then whether the trial or study design used to generate the RWE can provide adequate scientific evidence to answer or help answer the regulatory question meeting the standard, and then whether the study conduct meets FDA regulatory requirements. So I'm mostly going to be talking about, next slide, please, the RWE study design approach, but I'll also reference a little bit the EHR and claims data. And I also wanted to note that there are many terminological or definitional issues that are still outstanding in the field. And FDA published this paper, Randomized Observational, Interventional, and Real World, What's in a Name, to try to help clarify what some of those terms mean. And I call your attention to it because I think it's a useful guide. Next slide. This graphic attempts to illustrate the whole spectrum of real-world data and study design. So from left to right, there's increasing reliance on real-world data. You can see that across the bottom. And on the top of this slide, you can see that there's also a methodological movement from randomized or interventional studies to non-randomized interventional, and then non-randomized non-interventional, or what we would traditionally call observational studies. And the range of activities include support for site selection, assess enrollment criteria and trial feasibility, selecting outcomes from real-world data, but then also randomization in the real-world setting, or identification of control arms, and then the traditional cohort studies. Next slide. So now that I've introduced the program, I'm going to shift a little bit to the activities in the Sentinel system to support FDA's understanding of RWE generation. Now, you've already heard about some of this, or at least alluded to, and so I'm going to pick up on a few points here. So Sentinel has created and used for many years now tools for causal inference and observational studies in the Sentinel system. You heard about the causal inference master plan of the Sentinel Innovation Center to continue to develop those tools and capabilities. And then there are projects and capabilities in what we call the Sentinel Catalyst system, which is using the Sentinel infrastructure for interactions and interventions with patients. I'll just point to these these activities in Catalyst, and then John Concato will go into more detail about them. Next slide. So this slide illustrates all the kind of uses and tools that are available for someone, at least from within FDA, who wants to do some kind of evaluation of a medical product. So on the left, the question is, what are you investigating? You can look just at drug use or medical product use. You can look at outcomes by themselves, for example, to get background rates. Or what's of most interest to us when we're doing causal inference is how medical products and outcomes might relate. So FDA has built a whole range of tools supporting causal inference between medical products and outcomes. And you can see them listed here on the bottom in the red box. They include a very wide range of propensity score analysis methods, multiple factor matching, self-controlled risk interval designs, and interrupted time series designs. And each of these designs can be used to assess the relationship between medical product and outcome. And you heard in Trish Bright's presentation earlier this morning, or you saw in one of her slides, the analyses that were conducted through the ARIA system. And these would be the types of analyses that she referred to as L2s. Next slide. In thinking about how to go about this, the Sentinel Innovation Center master plan created a certain research logic. And this graphic illustrates that. And I'm not going to go through all the details here, but I just want to point out a few features of it. On the left, you can see there's three main components. There's a design layer, and that involves how do you design the study so that you can make a causal inference. And then there's the measurement layer. How do you achieve fit for purpose measurement? This relates very closely to the component of the FDA's RWE program and the recent guidance that came out on claims and EHR data. And then there's the analytics layer. How do you build the tools that allow you to achieve causal analysis, considering confounders, outcomes, and quality? Next slide. And you saw this slide earlier in Sebastian's presentation of the 4 pillars of the Sentinel Innovation Center Master Plan. The first 3, data strategy, feature engineering, and causal inference, are all together work to improve Sentinel's capabilities in this area. I'm going to talk a little bit about some of the causal inference projects. Next slide. So you also saw this in Sebastian's slide set, but I'm just going to pick out the 3 projects that are currently ongoing for causal inference. That's the evaluating targeted learning in EHR data, causal inference framework, and approaches for missing data. There are also several projects planned, and one I'll just call out that's not on this graphic, and it addresses one of the questions that was in the Q&A earlier today, is that under the PDUFA 7 commitments, there is a commitment to do work using negative controls to improve our ability to assess how well an analysis is working to be used for causal inference. So the targeted learning project is attempting to develop flexible data-driven machine learning tools for propensity score estimation with the superlearner method. That will incorporate a lot of detailed data from EHRs, and then to continue to do treatment effect estimation with targeted maximum likelihood, which is a doubly robust approach. The causal inference framework is to create a framework that would propose stepwise approaches to systematically address all the factors that we were talking about: key design choices, data, and analysis. And the idea here is that for FDA's work, but more generally, there needs to be a standardized, what I have also referred to as an industrial process that can be very efficiently applied to both design studies, but also assess their value. And then the third project is a project to develop methods to routinely identify missingness patterns from EHR data. And this is very important when thinking about EHR data quality. And it'll compare approaches to missingness given different underlying mechanisms. Next slide, please. And this is the same slide that Rich identified as a pointer to John Concado's talk. And I just want to highlight one key aspect of this, and that is that several of these projects involve randomization in the real world setting. And this comes back again to the one of the key aspects of the RWE program, which is that it involves both randomization and observational techniques. And the Impact AFib project, which is the third project on here, was a project that did involve randomization, and it showed FDA and the larger community that it was possible to do randomization in this setting, which gives us confidence that this can be a generalizable approach. Next slide. So then in summary, the real world evidence program is advancing. The Sentinel system has built many capabilities over the years for both observational and randomized studies that support FDA's understanding of RWE. And the Sentinel Innovation Center Master Plan provides a roadmap for improving RWE generation for observational studies by improving methods for causal inference. Next slide. And I'd just like to acknowledge the many folks who have contributed to this. I don't have as good a slide as Rich did, but there are many, many people involved. Thank you.
Thank you so much, Bob. And for those of you who are still joining after Bob began his presentation, Bob Ball is the Deputy Director of CDER's Office of Surveillance and Epidemiology within the FDA. So thank you so much, Bob. We'll go ahead and hear some further comments from our panelists. I will go ahead and turn it over to John Concado for his remarks.
Thanks very much. Thanks to all for attending today. And I'll pick up where Bob Ball left off to talk about the Catalyst projects that have been shown in the next series of slides. So next, please. The usual disclaimer that the views and opinions I'm presenting are my own and should not be attributed to FDA policy, and I don't have any conflicts of interest. Next. This is a snapshot from, or a copy paste, I should say, from the FDA Catalyst website. Just a reminder that FDA Catalyst, as a component of Sentinel, is an important addition to surveillance and research of marketed medical products. It leverages the Sentinel infrastructure and other capabilities to be able to answer a wider range of questions that can be addressed by the Sentinel system data alone, which is already considerable, of course. And so ultimately, Catalyst complements the existing post-market surveillance system. Next slide, please. So as mentioned, Rich Platt showed this slide, Bob Ball showed this slide, and it's sort of a table of contents for the remainder of my talk in terms of touching on each of these projects. So let's get started with the next slide. First, in an example of linking Medicare data to what's called the Reliance trial, the trial itself is comparing roflumilast, which is a phosphodiesterase inhibitor, to azithromycin, which is a macrolide antibiotic, to see whether they prevent COPD exacerbations. Now, the trial itself is a parallel pragmatic non-inferiority trial, which is designed to evaluate these two drugs in reducing COPD exacerbations, as I mentioned. So this is an example of a collaboration between FDA, Sentinel Operations Center, Department of Population Health Services at Duke, the link patients enrolled in the trial to their Medicare data. Next slide, please. So to continue with the focus on this project, the linkage of the Medicare data to the trial will provide additional information, important information on the primary outcome of all-cause rehospitalization or death, as well as selected secondary outcomes that I don't show here. It also provides an opportunity, one might call it a methodologic opportunity, to test distributed regression methods with vertically partitioned data. So advancing the envelope, in this case, in a very specific way, but nonetheless in an important way. And more generally, switching from the specific to the very general, the activity overall supports FDA's assessment of real-world evidence to help support, as Bob Ball showed, new indications for approved drugs, which is one of the mandates under 21st Century Cures Act. And it also will build and test infrastructure and methods to conduct pragmatic clinical trials going forward. Next slide, please. As an additional activity related to the same Reliance trial, we have a study that goes by the acronym CARE, C-A-R-E for COPD, asthma, and respiratory disease effectiveness. Work has already been completed as of 2021 in terms of feasibility assessments, characterizing the study population, and developing and having preliminary validation regarding potential endpoints. And what will follow from here in 2022 and 2023 as planned, as shown, would be a pre-replication of results from the trial. That is, and this brings back Sebastian Sneeweiss spoke this morning. He and his team, as most on this call would probably know, are overseeing the conduct of the RCT duplicate initiative, whereby trials are emulated using largely claims data from observation, using an observational cohort analysis approach. In any case, in this case, as is sometimes true for RCT duplicate, there's a pre-replication, so the results of the trial aren't even known, and an attempt will be made to, well, the observational analysis will occur, and then a comparison will be done between the two approaches. And then last but not least, an additional comparative effectiveness study that I don't have time to discuss. Next slide, please. The impact AFib has come up more than once. It stands for implementation of a randomized controlled trial to improve treatment with oral anticoagulants in patients with AFib. In the interest of time, I won't read each of these 3 paragraph equivalents, but I will say basically the underlying thesis from the first bullet point there is that patients could be change agents to initiate prescribing discussions with their providers. There was an early and a delayed intervention arm, and challenges were identified during the planning phase for this pragmatic trial. As it turns out, in terms of the association itself, the null hypothesis, as they say, was not rejected, but even so-called negative studies are very informative. So this is a very good investment in terms of moving the field forward. Next slide, which is the last of my content slides. And again, Rich and others have mentioned this, but the My Studies app, later rebranded as the COVID My Studies app, is a web-based configuration portal. This is basically in a secure storage environment gathering new real-world data. It was deployed in a randomized trial of patients with idiopathic juvenile arthritis in a registry study of, or collecting registry data, I should say, for inflammatory bowel disease. And it was most recently repurposed as a COVID My Studies app to facilitate enrollment in clinical trials during COVID, where infection control precautions, isolation, et cetera, was a challenge. Next slide, please. We don't have time, but we could talk about causality sort of in a theoretical academic sense. There are counterfactual models, there are interventionist models. The next level down, there are practical methods. We heard about targeted maximum likelihood, propensity scores, negative controls. We can go back to Bradford Hill's criteria from the 1960s if we wish. But basically, this is a practical approach on this slide to causality. Bob Ball showed this slide. I won't repeat it other than to say briefly, data fit for use, design adequate, and regulatory study conduct meeting regulatory requirements. So this, at the end of the day, is a user-friendly, reviewer-friendly, clinician-friendly approach. Next slide, please. My acknowledgements are shown here. And with that, I'll say thank you very much, and I'll pass the baton along.
Very much. We will go ahead and turn it over to our next discussant, Rich Forshee.
Hi, everyone. This is Rich Forshee. Can you hear me clearly?
Yes, we can.
Great. Thanks very much for the invitation to speak today. I'm going to talk a little bit about how we've tried to approach and operationalize some of the causal inference paradigms that have been discussed up until now. If we could go to the next slide. My team and I have tried to put together a graphic that describes our overall process. And one of the points that I want to make here is that when you're thinking about doing causal inference with real world evidence, you can't focus just on narrow technical questions. You have to make sure that you've got your entire process set up to give you the best chance of making appropriate causal inference from the data. And this really starts with asking the right kind of question for your analysis. And in terms of FDA, there's a few things that we always have to ask ourselves when we're in the question generation stage. The first is what we're proposing to study relevant to the FDA's mission? There are a lot of potential research topics that we could address that don't fall within the FDA's research mission. We also need to then prioritize according to what are the most important public health implications among the questions that we could be studying. And finally, we need to make sure that whatever we're studying will be able to get timely answers that can inform the decision making that we need to do, and that the study is feasible. Next click, please. After we get the question right, we need to move to a couple of the topics that were discussed by Bob and John earlier in this session. We need to make sure that we're using fit-for-purpose data, and we need to make sure that at the design stage, when we're writing the protocol, that we minimize bias by design. Next click, please. Also at the planning stage, we need to build in numerous pre-specified sensitivity analyses, especially for any critical assumptions that we're making regarding the data. Next click, please. And finally, we need to build into our design methods to help identify and quantify any remaining bias that may still be in the data. Next click, please. And then finally, there is a feedback mechanism that takes place here. The sensitivity analyses and the efforts to identify and quantify the remaining bias oftentimes lead to new and unexpected questions, and so we need to go back to the top part of the diagram. In the rest of this presentation, I'm going to briefly show a couple of examples of how we've operationalized some of these approaches. Next slide, please. For the examples I'm going to be using in the rest of this presentation, we're going to be looking at some of the work that we've done on studying the vaccine effectiveness of the zoster vaccines that have been available in the United States. And for this, we use the Medicare claims and enrollment data as the key data source for the analysis. And there are a number of reasons that we believe that these were fit-for-purpose data for these particular analyses. These data have extensive demographic and health data for all of the beneficiaries. They're a very large database that includes most people 65 years and older in the United States. For the particular exposures and outcomes that we were looking at, we believe that those were reliably captured in Medicare. This isn't to say that all exposures and outcomes are reliably captured, but these were expensive vaccines that were likely to show up in the claims data, and the outcomes were severe enough that we expected to see most of those captured in the claims data. Medicare included the relevant patients that we had, and there was little missing data on the key variables that we needed. I've noticed in the Q&A that a question has come up about the data lag, so I did just want to mention that as part of the FDA's agreement with CMS, we do have timely access to the data. Generally within about 90 days, we think we've got near complete coverage of the claims data that are available. There's always a little bit of time between when a claim is submitted and when we see it in the data, but we have pretty timely access with the agreements that we have in place. Next slide, please. In my remaining time, I'm going to give just a couple of examples of things that we've done to identify and quantify remaining bias in the analyses. Next slide, please. Great. So in this slide, we're showing an example where we have linked to external data, data that is not part of the overall claims, in order to assess how well the matching that we did on the observable data in the claim system, how well that also improved balance among variables that were not available in that system. The specific data that we're using is called the Medicare Current Beneficiaries Survey, or MCBS, which is a random survey that's nationally representative of people who are in the Medicare system, asking a number of questions that we can't get at through claims, including things such as healthcare utilization, with questions such as, do you agree that you would do almost anything to avoid going to the doctor? It also measures a lot of daily activities, such as difficulty doing heavy housework. And these are the kinds of data that we are oftentimes concerned about, and from a confounding perspective that we can't directly get at in the claims data. However, the MCBS is linked to the claims data, and so we were able to explore whether we were able to improve balance here. The dark-filled circles are the post-matching standardized mean differences. The open triangles are the pre-matching. And you can see for many of the variables that we were looking at, once we had done matching on the variables available in claims, we had much better balance among the variables that were not included in the claims data. This gave us some greater confidence that we had balance across the cohorts. Next slide, please. Next slide. So here's another example that we did that was trying to use, at the time we were calling them falsification outcomes a few years ago. Now they're more commonly called negative controls. So in this particular example, we looked at 13 falsification outcomes that we did not expect to be related to zoster's vaccination. The good news that we saw was that across both the primary and the secondary analysis, we were relatively evenly divided across the 1.0 no effect line, the dotted line that you see in the middle of the graph. However, we did see some statistically significant associations that were still present. They were, however, smaller in magnitude than the association for the zoster vaccine and herpes zoster that we studied. And this goes back to one of the ways in which these kinds of sensitivity analyses can feed back into your research questions. Circled in red near the bottom, you can see that there were a few outcomes that had slightly elevated risk for people who received the vaccine. But these were generally relatively mild conditions for which people may or may not choose to go to a doctor and have it appear in the medical claims. So we were continuing to explore whether there was some sort of health-seeking behavior effect that may have been leading to some of these associations. Next slide, please. So those are the quick examples that I wanted to give of our approach at CBER. All of our work has been done with many collaborators from across the FDA. We've also worked closely with the CDC. CMS has been a wonderful partner of ours for more than a decade now, and Acumen is the contractor working with CMS to do the data analysis, and we think this has been a really exceptional collaboration among these federal partners. Next slide, please. I'll just leave you with a photo from our White Oak campus, which I haven't seen in many, many months now. We have a number of benches across the campus with important messages for us. And this is from a court case involving the FDA, saying that the FDA insists that reality matters. And I'll go ahead and end there. Thank you very much.
Thank you so much, Rich. I will go ahead, in the interest of time, turn it over to Gian Mario Candore. Gian Mario, I'll let you take it from here.
Good morning and good afternoon, everyone. Just trying to put the video on. So my name is Gianmario Candore. It doesn't allow me to have the video. Apologize for that. Okay. Good morning or good afternoon, everyone. My name is Gianmario Candore. I'm a statistician working at the European Medicine Agency for the last 12 years. And in the next 4 slides, we're going to show our approach to real-world evidence. In every slide, we will go more and more in detail, starting with the general approach and ending on how we see we can translate from real-world data to real-world evidence. Next slide, please. This is our disclaimer, so the view expressed are my personal view and not of the agency. Next slide, please. This is our general approach to real-world evidence. We do recognize that there are 2 occasions when regulation meet real-world evidence. The first one is when the evidence is produced and provided by the pharmaceutical company to support their application and their submission. Here, our role is to provide guidance, to promote the use of high-quality data, and to help the developers with the best practice recommendation templates. Some example of what we have done and what we would like to do here. One thing that we have done is that we published a guideline on registry-based studies just a couple of weeks ago. And we would like to provide more clarity on definition and quality assessment criteria that could help the developer when they provide real-world evidence in their application. If you click again, we will see the second instances where we meet real-world evidence. Here is when the network itself produced the evidence that is needed to support the committee decision-making. So here the role of the network is to produce analysis and studies that can help the committee to fill the gap in knowledge that they have. For instance, to provide additional evidence or to provide more up-to-date evidence that help reduce the uncertainty when they have to take a decision. We are now going to focus on the right side of the slide, so the evidence that we are generating ourselves. Next slide, please. So what we are trying to do here is to create our own version of Sentinel or CNODES. And we recognize this is a complex task that includes many different activities. So we have classified these activities in 2 big areas. All the activities that aim to increase the generation of real-world evidence, so to be able to generate real-world evidence, are under the category what we call supply side, that are on the top left of the slides. Here we include activities like we need to know which data are available, what are the characteristics so that we can identify the best data to answer a question, as it was shown before, and how we can access this data. We also need to have skills, methodology, and technology to perform analysis studies. And we need finally to have processes to request an analysis, to provide the results to the requester, and an organization that support the processes. Then we have the demand side. Here we include all the activity that aim to understand what is the needs of the end user for real-world evidence. Here is where we collaborate with our scientific committee that take the decision and understand how they can use real-world evidence, for which question, for which application they can use it. But we also work with the committee from the member state in Europe, and to highlight that we also work with organizations outside medicine regulation. So we're working with European Commission, HTA bodies and players to understand what are the real world evidence needs, because we would like to expand this service also to them. Next slide, please. So Darwin is at the core of the way we want to produce and generate evidence ourselves. And said it resembles similar system like Sentinel CNODES, but it has its own peculiarities. We can define Darwin as a federated network of data, but also expertise and services. And is built around 3 actors. So you can see that on the top left of the graph, we have the Medicine Regulatory Network actor. Here we have the European Medicine Agency that provide leadership and oversight to Darwin, but we also have all the committee and, as said before, the member state and the European Commission that can request analysis via EMA. Then at the center, we have this big orange circle that we call Coordination Center. And this is the organization that manage the network and the execution of the studies on behalf of EMA. And finally, we have all the blue nodes at the edge. These are the data partners. So these are organizations that have access to data or can require analysis to data. And you can also see that we have data permit authority. These have been built through the European Commission and the European Health Data Space, and they are a way to have access to a much broader and deeper set of data within each member state. Darwin, as also Sentinel and Keynote, is built on two key principles. Data stay local. So the analysis is run on these blue edges, and then only the aggregated results sent back to the coordination center. And also we will use a common data model that will help to run analysis faster and to increase consistency. Differently from what's happening on the US, our data model might also have semantic harmonization, meaning that we will have translation to one common dictionary. And finally, how is our approach helping translating from real-world data to real-world evidence in the next slide? We want to highlight 4 activities. As said, we cannot run a study without data. That's why our first activity is related to data. We want to improve both the data discoverability, creating a catalog that shows which data sources are available, but also what are the characteristics of this data source so that they can be selected according to the research question we have in mind. So we are developing a set of metadata that can be used to select these data sources. And we also want to improve the data quality of the source available. So we are developing a data quality framework that can be reproduced across different sources. Second, we do recognize that we are at the beginning of a journey. That's why we have a stepwise approach. We are planning and doing pilot with each of our 7 scientific committees to help them to articulate their research question, but also to test processes and methodologies. And here we are starting with the more traditional cases where the methodological challenges are less pronounced. So we are starting to work with them with disease epidemiology question, drug utilization, safety question. Third, in terms of methodology and capability, there are 4 initiatives we want to highlight. The first one is our continuous engagement to update guideline on best practice in pharmacoepidemiology. We have just updated our NSEP guideline thanks to all the work done on real-world evidence, on COVID-19. Then we plan to create next year a working party that focus on methodology. And for the first time, we will have experts dedicated in real-world evidence. We are working with the European Commission on a call to refine methodology. So this is a big call that has been already published. And one of the output of this call could be to create a framework to enhance causal inference. So what we want to do is to create some practical guidance that will help the researcher to plan study enhancing causal inference. And we're also developing training focusing on the regulatory use cases. Last but not least, I'm not sure that you can see it in the slide, is that we promote transparency. So each of our protocol and studies are published on our catalog of data sources that is publicly available and is called EU Pass Register. Thank you very much for the attention.
Thank you so much, John Mario. We will go ahead and turn it over to our final panelist for this session, Josh Gagne. I will turn it over to you.
Thank you, Rachel. I want to thank all the organizers for the opportunity to contribute to this important discussion. I want to start by saying that I am an employee of Johnson & Johnson, but anything that I say is my own opinion and does not necessarily reflect those of my employer. Having worked on Sentinel for the last decade, it's really exciting to see that the progress that's being made in the Innovation Center Master Plan, and also all the really important work that Sentinel and BEST are contributing to help us safely and effectively find our way out of the COVID-19 pandemic. So kudos to everyone who has presented so far. So in reacting to what we've heard in this panel and throughout the day so far, I want to make 3 key points. And to borrow a quote from the musical Hamilton, the COVID-19 pandemic has helped us more fully appreciate 3 fundamental truths about real-world evidence at the exact same time. particularly in the context of the vaccines that are now available in widespread use in many parts of the globe. Number one, the pandemic and now these vaccines have really demanded rapid generation of real-world safety and effectiveness information. The VAERS system, as we know, is already set up and is a spontaneous reporting system that's global in its reach, and it's played a really important role in our understanding of very rare adverse effects that may be associated with certain of the vaccines. I think where we really need to get with real-world evidence and the infrastructure around the real-world evidence enterprise is a similarly responsive and global infrastructure. We heard Dr. Platt earlier in the day described a project in which Sentinel is using a single query to run analyses across multiple countries. And we've now heard about the EU's plans with Darwin. So I think it's really exciting to hear about these really important initiatives that are going to drive us closer to a truly global infrastructure for real-world evidence. But we need to continue to work on these connections. We need to find a way for all the major initiatives around the globe, Sentinel, Darwin, CNODES, Odyssey, to come together so that we're really ready to respond quickly and with as massive a data source as we can possibly compile, in much the same way that the VAERS system is readily available to respond to a pandemic and also global in its reach. We really need a global solution to global problems such as a pandemic. Number two, across the field of pharmacoepidemiology, there continues to exist an opportunity for low quality real world data studies to be published and even to inform decisions that patients and their physicians and others are making in the context of something like the pandemic. There's no question about the quality of the work that's being done in Sentinel and in BEST, but unfortunately there are many lower quality studies that continue to be published out there in the broader real world data sphere. This issue has really come to a head in the context of the pandemic. We see that the ubiquity of and access to real world data far outpaces the ability of researchers around the world to perform rigorous studies that produce valid results. On nearly a weekly basis, if not a daily basis, we see studies that are published in major scientific journals that utilize what many of us would not consider to be best practices in pharmacoepidemiology. Dr. Ball described the multiple frameworks that the FDA has issued with regard to developing real-world evidence, and I applaud FDA for developing these materials, and I appreciate that the frameworks that both he and Dr. Forshee presented in helping think through causal inference are really driving the agency's view of how to do and interpret high-quality real-world evidence. I think that there continues to be a major gap between the quality of the work that are performed in these sorts of environments compared to the broader ecosystem. And I think there's a real opportunity through these frameworks and through the work of the Innovation Center within Sentinel and within BEST also to really drive a more fundamental and systematic shift in the quality of evidence. As Dr. Forshee pointed out, reality really matters. And I think in the context of real world evidence studies, reality matters in terms of whether we're getting the methods right and we're producing valid results. Number three is that as a field, we've come a long way in what I would consider to be version 1 of our approach to the adoption of real world evidence, namely in the category of inferential or signal of risk evaluation. I think what we're seeing with the pandemic is that we really need to quickly get to an adoption plan for what I would call version 2, which would be moving beyond just causal inference into the signal detection space. This is very much where the BEST and the vaccine safety data link analyses are going to some extent. And it's also part of the Innovation Center master plan. So I think we need to quickly be thinking about guidance documents and other frameworks for interpreting signal detection studies as well. So let me stop there. I thank everyone again for the really critical work that they're doing in the context of the pandemic, and I look forward to the panel discussion.
Thank you so much. Thank you to all of our panelists today, including our opening presenter, Robert Ball, John Concato, Rich Forshee, John Condore, and Josh Gagne. Thank you all so much for those opening remarks. On our next slide, we'll offer some questions to get the discussion started. And as a reminder for those of you who are attending today, feel free to submit questions through our Q&A function at the bottom of your Zoom window. We welcome any and all questions from anyone who had a chance to listen in to this wonderful beginning session. So we've got a lot of questions already in the chat for our panelists, and these questions are driving some thoughts around questions that I'd like to ask, questions that we see here. But I think what I'll do is I'll kick it off with the first question that's here, and I'll open this up to our panelists. Where are there parallels between FDA's and EMA's framework, or at least work rather, on generating and using real-world evidence for causal inference? We'll go ahead and start there, because I know that that's probably a big question, and I think a lot of folks on the line want to at least hear your thoughts around this particular question. So Josh, I'll go ahead and start with you, if that's okay, since you are our last session panelist.
So I think that one of the commonalities is that we need, as we think about the pandemic as an example of a really global situation in which we need real world evidence, I think that the sooner we can get Darwin and Sentinel and all of these initiatives helping to address the same questions will be useful. I can't speak to the specifics about how Darwin and Sentinel, for example, are similar or different, but I think the overarching theme is that they're addressing the same fundamental global public health problems. Medical product safety and effectiveness is truly a global question. It's a global endeavor. And so I hope that the other panelists will be able to identify where there are synergies. There are potentially some differences in the way that the initiatives are thinking about common data models. I know there are also initiatives to think about how to link up other common data models. And so I'd be curious in terms of how, for example, Sentinel is operating with respect to the multiple country analysis with the common data model, and eager to hear the other panelists' thoughts around the similarities or potentially differences between these initiatives as well.
Thank you so much. You have a global perspective that you definitely bring to this discussion. So I'm glad you were able to sort of kick off this question with your thoughts there. Anyone else on the panel would like to tackle that question?
Hi, this is Bob. Yeah, so just to pick up on Josh's last point, there, in a general sense, you can think of a common protocol and a common analysis as a framework for how different systems can operate. And we work very closely with EMA, and I think you'll hear tomorrow in this session on the COVID work about a common protocol approach where we mutually implement a protocol that we've agreed to in our particular data systems, recognizing the particulars of both the healthcare systems in which we operate, as well as things like the common data models that Josh was referring to. Rich Platt in his talk mentioned how we were able to demonstrate that you can run a single analysis in CNOS and then in the UK and Netherlands system. And at one level, that's ideal because everything has already been translated, and then there isn't a need for kind of translation. So I think that these two approaches will be required for the foreseeable future, but I think work in understanding how common data models can be translated into each other is an important future effort.
Wonderful. Thank you so much for that. And with the time that we have, I do want to bring up a question that came up quite a bit in the chat. So thinking about certain disease focus areas, specifically looking at rare disease patients, what are implications there? As we often know, rare disease patients come at a low N or low volume number. And so data on these populations, including within larger federal programs like Medicare and Medicaid that often bring lots of data to the table, rare disease patients, or at least their representation in those data sets may not be adequate. So as we think about populations like them, what are some limitations then that we should consider in study design, and also even potential limitations in developing common data models when we think about patients that are often underrepresented simply by nature of the rarity of their disease.
This is John Concato. I might start with an answer to that question, but I want to start at a very broad level and ask that we keep track of where we are on the so-called real-world data landscape. It is true, certainly, that would say rare diseases using Medicare data might be quite challenging. And I think Rich emphasized this in one of his first slides about asking the right question. And Bob Ball likewise made comments to this. So I think we have to remember that there are different types of real world data. And while claims have been sort of the initial focus of Sentinel, and we've heard that EHRs are making more and more inroads, let's not forget registries. And certainly rare disease registries are more common than common disease registries to a certain extent, or certainly reflect a larger proportion of the affected population. So let's keep our eye on the prize here, which is improving public health, by saying that we have to be thoughtful. And I'm not going to push back against Josh, but I will say that, you know, the peer review process, we often said in academia, you can get anything published anywhere. And that's not a knock on peer review. But I think if we take an objective look at what's happening here, it's not just the few success stories, if one wants to characterize it that way, but I'm going to echo what Bob Ball mentioned in one of his slides, the 2020 paper in pharmacoepidemiology and drug safety. I think we have to be really careful about talking about interventional versus non-interventional study design. Exactly what was going on. It's too, design-wise and data-wise, it's too easy to talk about RWE or RWD and not have clarity in terms of what we're addressing. So I just want to make a plea for us to, in general, with our day-to-day work, it's wonderful shorthand, right? But randomized trials versus observational studies is largely a false dichotomy. And sometimes we're so busy that we lose track of exactly what we're talking about. Thank you.
Rachel, if I can add.
Looks like we've got two panels. We'll start with John Mario, and then we'll turn to you, Rich.
Yeah, I just want to echo what John just said. There is a landscape for real world data, and we are aiming, especially with Darwin, to have what I can hope to have the right balance. So for us, registries are at the center of what we would like to work with. We have already started seeing how we can collaborate with them, and we have to have some registry included in the Darwin network so that we can have access, analyze them faster. As already said by John, even here in Europe, we see a huge amount of interest on rare disease and on providing evidence on rare disease. So we are working quite hard to have access to registry, and we are working right now to collaborate and understand how we can collaborate better with them. So yeah, it's not only electronic record that we need to have.
Mario, Rich, I believe you had something to say as well.
Yes, I just also wanted to follow up on John's point. While it is absolutely correct that for very rare diseases, claims data aren't very useful, with some of the large claims databases that we have, we still can explore pretty rare outcomes. For example, we've regularly studied the risk of GBS following a number of vaccines. And this is an area where we're interested in studying risks that could be at the 1 in 100,000 or a few in a million level of risk. And so these large databases can allow you to study pretty rare outcomes, though they certainly do have their limits. Thank you.
Right, and Rich, thank you for that point. But rare outcomes, I was mainly talking about sort of rare diseases and trying to get a comprehensive assessment of a rare disease population. But I think our points are consistent in just addressing different topics.
Yeah, I agree. I think they were complementary.
Thank you both. And you know, some of our attendees today brought up some questions in the Q&A around opportunities for collecting patient-reported outcomes data. And then also, John, you mentioned the COVID My Studies app. And so as we think broadly in response to the pandemic about approaches to causal inference that might have helped or bolstered your work, what are some opportunities to consider there, you know, especially as we think of, you know, collecting data you know, at the point of the person, as they might use an app like the COVID My Studies app, and report various patient-reported outcomes that way. You know, what are some opportunities there that come to mind?
Well, I could again make a general comment and ask my colleagues to fill in more detail. But, you know, not to put registries on a pedestal, but if you have, as was mentioned, prospective data collection, you could build in a patient-reported component the same way you would in a clinical trial. So that is one angle. We also, a slightly different topic, but the whole field of digital health technologies and the like, I mean, we could get more patient-relevant data. So it's really a mosaic on a huge landscape. So it's too broad a question, I think, to answer with a single answer, but I'll defer to others to provide more detail.
Anyone else in the minute that we have left want to comment broadly on that? Just, you know, some opportunities, ideas, considerations.
Hi, this is Bob. Just one quick comment. The original My Studies app was developed to obtain information from pregnant women so that it could be linked to data inside the Sentinel system. And so that demonstrated the concept. And so that's another example of an opportunity, although there are challenges, of course, because it requires the people involved to provide the information, and so it's not necessarily a foolproof process.
Right, and thanks, Bob. The My Studies was indeed designed to bring the data directly into the healthcare record, so it could be pulled later, so to speak, into studies as we're talking about. Thanks.
Wonderful. Well, thank you to all of our panelists. This has been a great discussion. I want to thank everyone again. Bob Ball, John Concato, Rich Forshee, John Mario, Josh Gagney. Thank you all again for your remarks, the opening, and also your discussion points as well. I'm sure everyone was happy to hear some of their questions even answered in the Q&A. So I'll go ahead and turn it back over to Mark McClellan, who has rejoined us. Mark will take it from here.
Great. Thanks, Rachel. I'd like to thank all of our panelists from the first two sessions today for covering a tremendous amount of ground related to the Sentinel program. I'm very pleased to be here with you all for this last session with Rob Califf. Rob is a former FDA Deputy Commissioner and Commissioner. He's currently Senior Advisor for Verily and Google Health, working on a range of initiatives intending to bring data to bear on important questions of evidence. So given all of that, and I know Rob's deep interest in all things FDA, I can't think of a better person to have this discussion about building robust evidence generation sessions. And Rob, thanks very much for joining us. I'd like to maybe start this out with a where we've been, where are we headed approach here, where if you look at what has happened in Sentinel so far, it's come a long way towards, you know, a goal that you and many share of trying to get to a truly learning healthcare system where we're generating evidence routinely in clinical practice to answer the many questions that go unanswered or inadequately answered or wrongly answered today. And Sentinel's been a leading effort in that regard since its formation. I guess we're at the 13th Sentinel annual meeting now, so it makes the program officially an adolescent. So started out with some very important congressionally mandated missions related to better understanding the safety of medical products on the market, as we've talked about, starting out with a lot of reliance on claims data, some additional sources, but really now moving into a much richer array of data, including electronic records, some patient-generated data like the app that we talked about earlier today, and into some applications well beyond safety into effectiveness questions as well, with a number of ongoing analyses policies. It's part of its latest 5-year strategic plan, halfway through that, covering issues related to more sophisticated data analysis, more appropriate application of methods, really applying lead source of applications of that FDA real world evidence framework that I think every single session came back to today. So maybe we could start out by a little bit talking about where you'd like to see things go, and maybe any initial comments about where Sentinel is on the path to getting there. And then I think we can go into these issues in a little bit more detail. I should also say, for those of you who are with us, any other questions that you'd like to ask Rob, please send those along too. So Rob, over to you. Thanks for being with us.
Yeah, thanks, Mark. It's good to be able to talk about these things with you. And as you all know, you're in the Duke environment now, and I got spoiled as a medical student in the 1970s because I could see the power of what happened if you measured what happened to people in medical care and then followed them for life, which is what we did. But it was only with regard to one specific issue, medical treatment or surgery for coronary artery disease. And I was so excited by it. My very first article predicted that within 10 years of 1981, we would be routinely informing people with decision support coming from the evidence generated by all the other people like them through the electronic records, which would be ubiquitous by then. So here we are, 2021. We're nowhere near where I thought we'd be in 1991. But I got to say that, I think as I've gotten a little older and maybe wiser or more cynical, I'm not sure which one, it's interesting how things begin. They gain some momentum, and then when enough engines are pulling in the same direction, the progress becomes logarithmic or exponential and not just linear. And I think we're just in the early phases of that place now, and it's evidenced by the presentations from the 3 different centers with their programs and the commonalities among them and the wide array of academics and medical products industry and regulators working on these common methodologic and practical issues. So you ask where we should be, where's this going? I mean, I can say for sure, working in the alphabet environment, that people are interested in things they can do that impact their well-being, the risks and the benefits, and how they compare with each other. Because most people, they don't care in the theoretical risks and benefits, and I love that quote from the FDA campus. What they want to know is, if I got a choice between A and B, which one is going to be best for me or my family member? And of course, if you're a clinician, whether a doctor or a pharmacist or a nurse practitioner, you basically got the same question with a fiduciary interest of your patient that you're looking after. And I don't know, we are only guessing until we get to the point that we can really use these ubiquitous digital sources of information essentially continuously. And, I thought the speakers today did a really good job of pointing out, written in the Cures legislation was a lot of the framework for this to happen. And it's pretty exciting to see the way it's been carried forward, essentially by all the sectors that are reflected here. But we got a ways to go. And I'd also point out, in the midst of all this, several speakers referred to this issue, but we also have very dangerous misuse of the technology, making claims without regard to the appropriate methods that were discussed here today. And so, it's wonderful that we have access to the world's digital data now. And almost everyone has a cell phone, so the potential to interact and communicate is a huge advantage. But by the same token, misuse of that technology can lead to very rapid spread of bad things that are dangerous to people. And we're going to have to adapt to that. But ultimately, I think a really interesting role of the FDA historically has been to lay the groundwork for the practical methods that actually work, as opposed to the theoretical methods, which also need to be worked on. But it seems like, particularly in recent history, the last 50 years, when the FDA and the medical products industry and the associated academics work through the methods and make all the mistakes they make and correct them, with the fine tuning being how do you inform a good decision? It really gets the whole field on the right framework. And I'll just say one other thing related to this. The point was made several times today that not everything under the sun related to health and medical care is under the FDA's direct purview. I've tried to relate how indirectly it sort of is in one way or another. But I really do think it's going to be an important time for FDA and CMS and NIH and CDC. I think is well evidenced by the COVID response to really work together across the span of time that is relevant to how well people do. So even if it's not directly in the FDA's wheelhouse, FDA working with CMS or CDC could be extraordinarily powerful in answering the questions that people need to have answered to have better health.
Well, I want to come back to that about how better use of real world data to turn into real world evidence can help with the questions that people are asking every day. But I'd like to get there from where Sentinel started, which, as you know, was really around surveillance and safety issues and kind of working with big data. You're right that it seems to be converging on where we're headed with questions about treatment effectiveness, which are now also increasingly using real world big data. But as you said, it's important to get this right. And Sentinel seems like it's been a critical part of setting the standards, having that basis in reality is, as we saw on Rich's slide. But maybe you could talk a little bit about data first. So I think a lot of people a decade or so ago thought with big data, lots of analysis, lots of AI and machine learning, it would just be pretty straightforward to learn a lot more about, as you said, what mattered to particular patients. It's turned out not to be that easy because of the complexity of data and some real issues in data quality. And one of the major areas of Sentinel activity in the past and today and going forward, as we talked about, is understanding whether different data sources, increasingly rich data sources, are fit for purpose, whether it's electronic health records, patient-generated data, registries that could be used prospectively for more sophisticated studies. Maybe you could, any thoughts about the data piece of this FDA framework and strategy for setting the standards right on evidence generation from the real world?
Well, let me tell you, since Amy Abernathy left the FDA and joined Verily, I've been hearing about data nonstop. As I think you know, that is her big thing, the quality of the data. And I was really pleased to hear the discussion of how machine learning and other methods can be used to improve the quality of the data. But ultimately, you need measures that are context specific for how good the quality of the data needs to be to draw conclusions from analysis of that data. I'd also point out that no matter what we do right now, as best I can tell, we need this. Automation would make a tremendous difference in a number of areas, but we're still going to be left with a significant amount of work that's human labor because it is so contextual healthcare data. And I often use the analogy around the alphabet environment of maps where, you just take it for granted these days that you can get in your car and your car sort of knows where to go when you tell it where you want to go. And it's constantly updated, and it's all based on referential data, which is very highly curated and maintained. But all the roads in the world are a tiny fraction of the data you need for a single human being, if you really get into the depth of what we can currently measure. And so we're dealing with, I think, one of the most complicated problems that exists. And all the power of Google's, you know, as we've talked about related to the Care Studio project that Google has worked on, can't fully automate it. It's got to involve interaction with clinically knowledgeable people who understand the disease and the of interest, the therapeutics of interest, the problem that's being addressed, and of course the methodology that comes from the fundamental disciplines of statistics and epidemiology. It's a team sport, but ultimately, I feel like we're moving quickly now to the point where, given a particular problem in a particular context, we can define whether the data are high enough quality to use. Now, the method applied to the data to draw an inference, that's another issue.
Well, that was going to be my next question. So we heard a lot about how Sentinel is helping set the standard for developing fit-for-purpose data for a number of clinical circumstances and important decisions. But as you point out, the methods matter too. And there too, I have to say, Rob, I've seen important progress in how the Sentinel Initiative is being regarded. I remember in the early days of this program, there was a important effort to go out of the way to say we are not looking to this data, for example, to generate and identify new kinds of safety risks. It's more about confirmatory studies or exploring and refining whether a signal that we think might be there is really there. Flash forward to today, where we heard not only a number of discussions about causal inference, but also Josh Gagne saying, and I think being echoed by others, well, when is Sentinel going to get into really doing that prospective signal detection for new kinds of new kinds of risks, which to me suggests a lot more confidence in the methods. We heard about those too. In the observational context, propensity scores, other methods for assuring matching, a lot of work by FDA and Sentinel and its many partners in that regard. And then I forget what the exact quote was. I think it was like, well, there's I think from John Concato, a false dichotomy of randomized versus observational, really trying to understand the underlying properties. So, and we've heard about some examples of even doing some randomization, some practical randomization in Sentinel. So where are we on the methods, and can Sentinel help move those forward as well?
Well, first of all, I think it ought to be noted, I mean, Sentinel was a bold move when it started. And I know you were very much behind it and had a role in making it happen. But during my time at FDA, I learned that both Janet Woodcock and Jeff Shuren were very focused on this as a direction to go. And I always admire people who take on a problem when it's not popular, and but they're right. So they have and I think this is another key role of FDA, to be the beacon of verity and I guess fairly approaching problems even when there's going to be criticism, because it may be a little easier at FDA because no matter what you do, you're going to be criticized, so you might as well do the right thing. And in this case, the fact that Janet ended up putting CDER money into Sentinel and just forcing the issue when there were a lot of people who said it just couldn't be done. People wouldn't share their data. That actually took spending money to do it, as you well know. And, those budget discussions are not easy from the FDA perspective. So I feel like we ought to give due credit to those who persevered and got us to where we are. But I think this is a group of experts on this call, but in the public, I would modify a little bit of what John said about or whoever said it about the false dichotomy. I do think randomization, is an amazing tool that we need to understand and use when appropriate, that is fundamentally different than trying to make causal inference from observational data. And sort of the middle ground is prospective observational studies, where you have a little more built-in, not a little, often a lot more built-in ability to control for confounders and time zero. Also want to call attention to the time zero problem, which I think has been it's like the most valuable player who's not recognized. It's a really important issue that is really hard to deal with, because often treatment decisions are made when people are in the greatest state of change in their health status. Having said all that, we've come a long way, and I think we'll have an increasing number of situations where when the right methods are applied and it's done in full transparency, unlike the about 99.5% of observational studies that we currently see in the literature, but when it's done the right way, we'll see more of that thanks to this methodologic work. I think it will be considered a really important part of the decision-making framework. And as you pointed out, you know, in 2016, one of my favorite Jeff Shuren slides is the one that shows the change of the system from one-off studies done trying to piece together the data to a continuously learning system where you're always recording the information, and then you use randomization inside the system when it's needed. And I think we're closer to that than most people realize, because there's so many different vectors that are operating independently right now that are likely to come together.
Yeah, and we'd like to end, and if you don't mind, we're going to go a couple minutes over your scheduled time. This is a really interesting discussion, but we'd like to wrap up on that point. So you mentioned the work that, and you're right, this is growing throughout FDA, that Jeff Shuren and CDRH have done with NEST and their plans to move into 30, 40 plus applications in the coming months and years. We heard from Bess, and we're going to hear more tomorrow from the Biologics Center about how they're trying to build out a prospective registry capabilities, in effect, around vaccines that might even be able to integrate public health data from immunization registries, et cetera. So you can see this, to your point, these kind of prospective, well-curated, good data registries essentially being built that could help with Josh's point about, well, for this particular drug class, can we prospectively identify new kinds of potential risks and determine if there is a causal relationship there through this combination of more sophisticated methods, including addressing that time zero bias and maybe even including randomization in places. I want to contrast that, Rob, with, I know you've done a lot of work as we've been working on it together around building out platforms for making clinical trials easier to use and more widespread. Seems like if another word for a platform trial is a registry with well-defined data collection, hopefully much of it coming increasingly from real-world delivery of care, it seems like we're kind of maybe meeting in the middle on these kinds of efforts. And it just seems to reinforce the importance of FDA leadership through programs like this one in the US, as we heard about extending globally as well. So maybe you could end with just a few thoughts about where we're headed and how we can best build on the Sentinel progress to date.
Yeah, I'll try to be quick. I realize my answers have been long because
that's fine.
I'm pretty excited about this topic. But I mean, first, I'd just like to say we shouldn't only talk about risk. We should also talk about signals of benefit that were unanticipated. I am enthralled with one of the leaders of my generation in medicine, Gene Brownwald, writing that SGLT2 inhibitors are the statins of our modern age. They seem to work for everything. But let me tell you, when those drugs were being developed, it was thought they just made you pee out sugar and there would be no other benefits because there were no metabolic pathways that had been discovered. We still don't know why they help everything. And it was only because the FDA required that long-term trials be done for safety that the signal of benefit was seen. And we're talking about reduction in risk of death, which is a pretty good benefit in addition to heart failure and renal failure. So and I completely agree with you. The middle ground here is what I would see as a set of platforms within a broader platform in routine clinical practice where people's outcomes could be continuously assessed related to the medical products they received and also other factors, and then randomization inserted where it's the right thing to do to sort out the noise to figure out what's really most effective for people. I think the biggest issue we face is that right now our frontline clinicians are sort of glorified data clerks the way they've been treated. The latest thing from Bob Wachter, I'm sitting out in San Francisco now, ECSF, he published a thing showing that on Twitter, of course, showing that the average ECSF doc is spending 2 additional hours a night answering emails now from patients. And so that's a good thing when we figure out how to deal with it. But if our clinicians are spending all their time documenting for billing and answering emails, we'll never get to where we want to be. So we do have to solve the issue that biomedical data are more complex than roads or other kinds of data that we deal with. And I think that is the frontier to work on. I do think we're making progress there. And I think we will see it. The middle ground is going to be much as you described.
Yeah, and maybe an area too for CMS and payer collaboration. I know there's a lot of interest at the agency now and among many payers in getting data more about quality improvement and demonstrating better outcomes for patients rather than just the traditional fee-for-service billing. So I appreciate your point about how FDA going forward maybe should collaborate more with some of these other HHS agencies.
Yeah, and I think, Mark, I think FDA, much like it did with Sentinel to begin with, could do some pilots that would sort of force this issue.
Right, great. Well, something else to stay tuned for. Rob, I know you got a lot else going on right now. Really appreciate your taking the time. Somehow I think this isn't going to be your last discussion about these topics. Thanks for all your leadership and thanks for being with us today.
You bet, it's a real pleasure.
And I just like to wrap up today by thanking all of you for making this possible, especially all of our participants from FDA and their many collaborators in Sentinel and NEST and BEST. We heard about a lot of important developments. Rob and I just tried to put those in some longer term perspective too, but developments including an expanded base of better understood and better curated data sources, enabling richer and more reliable analyses. We heard about a number of efforts to make electronic medical record data more useful in complementing claims data and other data sources as well, and tools, AI and ML, be used not as in themselves, but as ways of increasing confidence in the fit for purpose nature of the data that are being used, the completeness, the provenance, and other related issues as well. We also saw how methods are being improved too, going along with the emphasis on data, and that overall FDA real world evidence framework, because I was struck by how much that came up across all of these different applications in the device center and the drug center and the biologics center, as well as in response to the pandemic, where we had to move quickly in terms of developing new types of evidence on important questions that we hadn't had to address before. We're going to come back to those issues tomorrow. But today, really a lot of emphasis on how what started out as a Sentinel Initiative is really growing up into a Sentinel systematic approach that is not only developing better evidence within the scope of its mission, but has also helped setting a standard that can be shared and can complement efforts outside of FDA and around the world to get us to much more reliable real world evidence systems, exactly as Rob was discussing. So I want to thank you all for the discussion today. More to come tomorrow, looking ahead, looking into the pandemic responses in more depth. So I hope you'll join us then. And we'll, in the meantime, wanted to thank everyone who contributed today through participation, through the Zoom Q&As, and to making this whole event possible. Please enjoy the rest of your afternoon, and we'll look forward to seeing you tomorrow.